Okay, guys, I have started again. So let's continue the topic. We have already completed the basic part of the renal system. If you face any issues, if you have any issues with the lagging, if you have any issues with the audio, you can all the time just keep a message in the chat session. Okay. Now, so what are we discussing about? We are discussing about the types of nephrons. There are two types of nephrons. One is the juxtamedullary nephrons as well as the cortical nephrons, right? So look here. The extramedullary nephrons are just 15%. Cortical nephrons are almost 80 to 85%. That's we have already discussed. And the cortical nephrons, they are surrounded by the peritubular capillaries. Already we have discussed about them. The peritubular capillaries are the interstitial cells of the peritubular capillaries which produces the erythropoietin. Okay, already regarding this we have discussed. And who surrounds the juxtamedullary nephrons? The juxtamedullary nephrons, they are surrounded by the blood vessels called as a vasa recta. So vasa recta is present around the juxtamedullary nephrons, and the cortical nephrons, they are surrounded. The cortical nephrons are surrounded by the peritubular capillaries. Now, what are the other functions? The other functions are the cortical nephrons. They mainly help in the formation of the urine. But the juxtamedullary nephrons helps in the concentration of the urine. They specifically ask you which nephrons helps in the concentration of the urine. It's the juxtamedullary nephrons. And one more difference, already we have discussed this. The cortical nephrons have short loop of Henle and the juxtamedullary nephrons have the long loop of Henle. Done. So different types of nephrons are also completed. Now after this, what else we have to discuss? Already I have discussed with you what is the glomerular filtration rate. The glomerular filtration rate is 125 ml per minute. Now, so which substances are actually filtered? Okay, in the nephrons, into the nephrons. For example, let me show you. See, this is the glomerular capillary. Let's understand this is the glomerular capillary. Okay. Now in this glomerular capillary, there are small holes present. Okay, there are small holes present called as a fenestration. These are called as a fenestrations. Now, down to it, there is glomerular basement membrane. Okay, this is the glomerular basement membrane. Now, down to it, what do we have? Here we are having the Bowman's capsule like this. Bowman's capsule, which are lined by the cells called as the podocytes. Okay, these are the cells called as the podocytes. Now, what I'm trying to put into your mind is this is the blood vessel, right? This is the glomerular capillary. Okay. Now, see all these three structures together. Okay, called as the glomerular filtration barrier. The three structures which I have shown you here are called as a glomerular filtration barrier. See, under this glomerular filtration barrier, which structures are coming? One is this endothelial cells. See, these endothelial cells with the fenestration. The endothelial cells are there with having the holes. Endothelial cells are having these gaps called as the fenestrations. So this endothelial layer followed by glomerular basement membrane, GBM, glomerular basement membrane, and this podocytic cells, PC, this podocytic cells. So this podocyte layer. So endothelial layer, the first one, this endothelial layer, glomerular basement membrane, and the podocyte layer. All these three together. Okay, see this endothelial layer, glomerular basement membrane, and the podocytic food processes. All these three together constitute the filtration barrier. This is the MCQ. Okay, this is the MCQ that they will ask you in your exam. Next, sir, which substances are easily filtered? Okay, which substances? For example, if I show you, which substances are easily filtered, sir, like this to down. Substances of 4 to 8 nanometers, not substances of 4 to 8 nanometers are easily filtered. Okay. Now, what are the gaps between the endothelial capillaries? In the endothelial capillaries, I have said you there are small holes present. These are called as fenestrations. Okay. And what are the gaps between the podocytes? See here, the podocytes, in between them, there are gaps present. See, these gaps are called as slit pores. So, slit pores are the gaps between the podocytes. Okay, these are the MCQs. So, glomerular filtration barrier consists of 3 layers. What are they? Capillary endothelium, glomerular basement membrane, and the third layer is the podocytic food processes layer. Okay. Now, which substances are easily filtered? The substances of 4 to 8 nanometers are freely filtered. And the gaps between the endothelial capillaries, or I should say the gaps within the endothelial capillaries, they are called as the fenestrations. And the gaps between the podocytes are called as the slit pores. Done. Now, after that, one more point which I want you to know is, so this glomerular basement membrane, this yellow color substance which I have shown you, this glomerular basement membrane is made up of type 4 collagen. Okay, before going to the exams, you should know this. The glomerular basement membrane is made up of the type 4 collagen, and this glomerular basement membrane, it is having which charge? Negative charge. The glomerular basement membrane is having negative charge. And in your exam, they will ask you, why there is this negative charge? Okay, this glomerular basement membrane negative charge is because of what? This negative charge, the glomerular basement membrane, see, GFB, glomerular filtration barrier, the glomerular basement membrane, it is having the negative charge. And this negative charge is because of very, very important MCQ, heparan sulfate, sialoproteins, and also glycoproteins. So glomerular basement membrane negativity, the negative charge of the glomerular basement membrane is because of the heparan sulfate, sialoproteins, and glycoproteins. This is the point which I want you to know. And next important point is, sir, this negative charge is there, right? What is the importance of this negative charge? So because of the presence of this negative charge, the glomerular filtration barrier, the glomerular basement membrane is having this negative charge. Because of this negative charge, albumin is not filtered. Okay, albumin is not at all filtered. Why? Why? Because if you look here, this is the glomerular capillary. I am showing you one glomerular capillary. These, what are these? These are the endothelial cells, right? These are the endothelial cells. Now, what is this one? This is the glomerular basement membrane. Now, down to the glomerular basement membrane, there is Bowman's capsule. This Bowman's capsule is lined by these podocytic cells. These are the podocytes. Now, what kind of charge is present over here? Negative charge is there. See, albumin is very small molecule. Albumin is such a small molecule. It's like, the size of the albumin is somewhere around the 4 nanometers or even less than the 4 nanometers. It's very such a small molecular weight molecule. It can be easily filtered, but it is not. It is not filtered. Why? Because albumin is also having negative charge. These plasma proteins, they are negatively charged substances. Albumin is a negatively charged substance. So negativity will repel the negativity. So albumin will come like this and it is repelled. The albumin is repelled because of the negativity. So now tell me, what is the importance? The importance of this negativity. The glomerular filtration barrier is having the negative charge. This negative charge will help in, or the negative charge will prevent the filtration of albumin. Okay. Now, after that, next what else you should know? You should know that the RBCs, WBCs, platelets, and all the plasma proteins like albumin, globulin, fibrinogen, all the plasma proteins and the clotting factors, all these substances, they are not filtered. Okay, they are not filtered. These substances are not filtered. Done, right? But if they ask you, the glucose is there, right? Is it filtered into the nephrons? Most of the students will think, glucose is very much important, it's not filtered. No, glucose is filtered, no doubt. Glucose and amino acid, these substances are freely filtered, no doubt. Okay, so glucose and amino acid, these substances are freely filtered. Okay, but they are filtered, but 100% they are reabsorbed. So glucose, amino acids, they are filtered and they are reabsorbed in the proximal convoluted tubule. Now, after that, for your exams, what else you should know? See, this is something very much important, especially from both physiology as well as pathology point of view. Guys, are you getting any disturbance? Any disturbance sounds are coming? Because some construction work is going on. Guys, are you having some disturbance? No, is everything okay, right? Okay. Okay. Now some construction work is going on. So, okay. Now let's continue. Okay, let's continue. Now for your exam, what you should know. Guys, please look here. These are the endothelial cells. Okay, this is the glomerular capillary. This is the lumen of the glomerular capillary. See, these are the endothelial cells, guys. Okay, where these endothelial cells are sitting? The endothelial cells are sitting on the glomerular basement membrane. This is the glomerular basement membrane. Now, down to the glomerular basement membrane, what do we have? These are the podocytic cells. Okay. Now, between the podocytic cells, I have said you, there are gaps present. These gaps are called as the slit pores. Okay, these are called as the slit pores. Now, look here, in these gaps, there is this one structure present. Do you know what is the name of this structure? This structure is called as the slit diaphragm. So, what I am trying to put into your mind is, sir, here, in between these podocytic cells, there is something called as the slit diaphragm. Okay, there is something called as the slit diaphragm. Now, the question is this. This slit diaphragm is made up of which proteins? This slit diaphragm is made there. It is made up of podosin. It is made up of podosin and nephrin. So, podosin and nephrin, they are the proteins which are present in. Okay, mainly Podocin, remember podocin and nephrin. So these proteins are forming slit diaphragm. They are forming the slit diaphragm. Okay, forget about the alpha actin 4, at least podocin, nephrin. Now, from the pathology, super important MCQ. If you have, or I should say, see this nephrin, okay, and podocin, they are the slit diaphragm proteins, right? They are the proteins which are present in the slit diaphragm. This nephrin protein, it is coded by a gene called as NPHS1. And the podocin, it is coded by NPHS2. Nephrin is coded by NPHS1. Podocin, it is coded by NPHS2. If you have any mutation of NPHS1, okay, NPHS1 mutation will lead to defect in nephrin, will lead to defect in nephrin. That will cause a condition. Hello guys, am I audible now? Is it coming? Okay, okay. So now let's continue. Guys, what are we discussing? Glomerular filtration is happening, right? Glomerular filtration is happening. 125 ml per minute. Why it is happening? See, glomerular filtration is happening because of a pressure difference of 10 mmHg. I am not going in detail about what are the different types of pressures. There are favoring pressures and opposing pressures like hydrostatic pressure, osmotic pressure. So many things are there. No one will ask you. No one will ask you all of them. What they will ask you is, see, there are certain favoring pressures. Okay, some pressures which will favor the glomerular filtration. There are certain pressures which will oppose the glomerular filtration. There are favoring pressures and opposing pressures. Favoring, opposing. Now, in between them, there is a difference. The favoring pressures, see, the favoring pressures, for example, the favoring pressures is 60 mmHg. That's the hydrostatic pressure. The hydrostatic pressure in the glomerular capillary, it's a favoring pressure. It helps in the glomerular filtration. It is 60 mmHg. Okay, it is 60 mmHg. But the opposing pressures, if you add, it will be 50 mmHg. Okay, it will be 50 mmHg. The favoring pressures are 60 mmHg. Opposing pressures are 50 mmHg. So now tell me who is more? The favoring pressures are more than the opposing pressures. By how much difference? So 60 minus 50. So 60 minus 50. 60 minus 50, how much? 10 mmHg. Okay. So glomerular filtration is happening with a pressure difference of 10 mmHg. That's the MCQ. I have already discussed with you. What is the formula of GFR? The formula for the GFR is UV by P. Okay, GFR or the clearance formula is UV by P. Okay. Now after that, what else you should know? How GFR is going to be altered in different conditions. Okay, there are certain conditions where GFR increases and there are certain conditions where GFR decreases. Okay, now look here, guys, just for a basic understanding. Now you know this is the afferent arteriole which brings the blood. Okay, which is bringing the blood. Okay, let me show you with the red color. This is the afferent arteriole which is bringing the blood. This afferent arteriole is going to divide into glomerular capillaries. Many small glomerular capillaries. Now all these glomerular capillaries also they will fuse and forms the efferent. This is the efferent arteriole. This is afferent arteriole. This is efferent arteriole. Okay, these are the glomerular capillaries. Here are the glomerular capillaries present. Now what is this one? This is the Bowman's capsule. Everyone knows Bowman's capsule and the proximal convoluted tubule, the first part of the nephron. Now my question here is, sir, what happens if this afferent arteriole is dilated? If afferent arteriole is dilated, like this, look here. So see, this is the afferent arteriole. Now what happens to the afferent arteriole? It is dilated, sir. Now if it is dilated, more blood will come into the glomerular capillaries. GC means glomerular capillaries. So more blood is coming into the glomerular capillaries. If more blood is coming into the glomerular capillaries, what happens to the GFR? GFR increases. Simple as that. So when you do afferent arteriolar dilation, more blood will come into the glomerular capillaries and more filtration will occur, more GFR will occur. Okay, so afferent arteriolar vasodilation increases the GFR. And who will cause this afferent arteriolar vasodilation? Who will cause this afferent arterial vasodilation? Prostaglandins. So prostaglandins are the substances which cause the afferent arteriolar vasodilation. Not only prostaglandins, also remember atrial natriuretic peptide. Okay, this was the question asked in the exams. Atrial natriuretic peptide causes afferent arteriolar vasodilation. Okay, now anything else? Someone is messaging. What happened? Okay. Okay, everything is okay, right? Done. Now, what else you should know? Now, look here, guys. Look here and tell me what exactly is happening over here. This is the afferent arteriole. Now, afferent arteriole is getting, okay, not this one. Not this one, this one. See? Yeah, here, this one. This is the afferent arteriole, right? Okay. So this is afferent arteriole, right? Afferent arteriole, now it is getting constricted. Now afferent arteriole, it is getting constricted. Now whenever afferent arteriole is getting constricted, you think logically and tell me what happened to the GFR. If it is getting constricted, less blood will come. Less blood is coming to the glomerular capillaries, right? So what happened to the filtration? Filtration decreases, GFR decreases. Simple as that. So now when you constrict the afferent arteriole, what happened to the GFR? GFR decreases. So who will cause this afferent arteriolar constriction? Afferent arteriolar constriction is done by substances like adenosine. So afferent arteriolar vasoconstriction, what it will do? It will decreases the GFR. Okay, it decreases the GFR. Now, next up. Now look here. In this example, in the third example, here I am showing you. This is the efferent arteriole, right? This is the efferent arteriole. Now what I am doing to the efferent arteriole? Efferent arteriole, now I am constricting. Okay, with the help of a substance called as angiotensin 2. This is the MCQ. Angiotensin 2. Okay, angiotensin 2 causes efferent arteriolar constriction. The efferent arteriole is now being constricted. When the efferent arteriole is constricted, tell me what happened to the GFR? Blood is coming, but it is not going out. Okay, blood is coming, but it is not able to go out. Why? Because efferent arteriole is constricted. So now blood will start to accumulate in the glomerular capillaries. The congestion is happening. More pressures will develop in the glomerular capillaries. So more filtration will occur. So efferent arteriolar vasoconstriction increases the GFR. Okay, initially increases the GFR, later decreases, but initially, most important point is, if you constrict the efferent arteriole, GFR decreases. Okay, now, next, if you dilate the efferent arteriole, what happens? See, you are dilating the efferent arteriole, sir, blood is coming, but blood is very easily escaping, it is not staying in the glomerular capillaries, it is very easy for the blood to escape. So what happened to the GFR? GFR decreases. So, at the end of the day, The point which I want you to know is only concentrate. First, let's talk about the afferents. Afferent arteriolar dilation. If you dilate the afferent arteriole, what will happen, sir? If you dilate the afferent arteriole, more GFR. If you constrict the afferent arteriole, GFR decreases. Done. Now let's talk about the efferent. Now, if you cause the efferent arteriolar constriction, efferent arteriolar constriction, blood is coming but not able to go out. So more filtration will happen. So more is the GFR. If you cause efferent arteriolar dilation, blood is coming but easily going out, easily escaping. So what happened to the GFR? GFR decreases. That's it. Next, after this, what you should know. Now we have to discuss about the mesangial cell and its relationship with the GFR. See, here I am showing you, this is the glomerular capillary. Okay. Now the red color thing which I am showing is the glomerular capillary. You can say this is the glomerular capillary because a lot of holes are there, wide holes are there. No, see, these are the fenestrations. See, this glomerular capillary, imagine this is the glomerular capillary. It is surrounded by the mesangial cells. So these mesangial cells are almost like a smooth muscles. They will contract, they will relax. So now think logically and tell me, if this mesangial cell, if it contracts, if the mesangial cell is contracting, what it will do to the glomerular capillaries? The glomerular capillaries are also closed. Now they are narrowed down. So what happened to the GFR? So mesangial cell contraction decreases the GFR. Mesangial cell relaxation increases the GFR. That's it. So these are also the MCQs which you need to know. Now after this, next important MCQs which I want you to know is, see, kidney, it is having some important property. It will regulate its blood flow. Okay, it can manage its blood flow. This is called as auto-regulation of the blood flow, as well as the kidneys will all the time want one thing. They want the GFR to be 125. They want to maintain the GFR. So kidneys, in any condition, they can manage the GFR. For example, if GFR is falling down, they will bring back the GFR to normal. If the GFR is increasing, they will bring down the GFR to normal. This is called as auto-regulation of the GFR. And MCQ is, this auto-regulation of the GFR is done with the help of a cells called as macula densa. So who is involved? Okay, who is involved in this auto-regulation of the GFR? This is also called as a tubulo-glomerular feedback. The same process, this auto-regulation of the GFR, it is because of tubulo-glomerular feedback. And who is giving this tubulo-glomerular feedback? Macula densa. So remember one point, macula densa, these are the cells which are giving the tubulo-glomerular feedback. So because of this tubulo-glomerular feedback, there will be auto-regulation of the GFR. Okay, so macula densa gives the tubulo-glomerular feedback, because of which all the time the GFR is maintained or regulated. Okay, next MCQs which I want you to know is, so this macula densa, it is sensitive to what? Sir, macula densa is there, yes, it is giving tubulo-glomerular feedback, it is maintaining the GFR, everything is good, okay. But this macula densa, it is sensitive to what? It is sensitive to the sodium chloride levels. Okay, so macula densa, see, macula densa is all the time checking what? This macula densa, it is checking the sodium chloride levels. Guys, I am not going through the entire thing. Simply remember, macula densa is sensitive to sodium chloride. Okay, next important MCQ which was asked in the exam. Sir, where exactly is this macula densa present? Macula densa is present on where, sir? Yes, it is sensitive to sodium chloride. It is giving tubulo-glomerular feedback. It is helping in the auto-regulation of the GFR. All the story is okay. But where this macula densa is present? The best answer is, see, this is the Bowman's capsule. Now down to it, what do we have? We have the proximal convoluted tubule. Now what is this one? This is the loop of Henle, right? Loop of Henle. Now what is this one? This is the ascending limb of loop of Henle. Now in the ascending limb of loop of Henle, what do we have? We are having a thick part. This is the thick part of ascending limb of loop of Henle. Okay, so this is the thick part of ascending limb of loop of Henle. After this, what do we have? We are having this distal convoluted tubule. Now after that, what is this one? Here you are going to have the collecting ducts and collecting tubules. Okay, now point which I want you to know is, see, macula densa is present where? This is the place where macula densa is present. Okay, so this is thick ascending limb of loop of Henle. So thick ascending limb of loop of Henle. So thick ascending limb of loop of Henle is the place. Thick ascending limb of loop of Henle is the place where macula densa is present. But if you don't find this answer, Okay, if you don't find this answer, then the next best answer is a junction between, this is the junction, right? Almost this is the junction. A junction between thick ascending limb of loop of Henle and distal convoluted tubule. So, thick ascending limb of loop of Henle and distal convoluted tubular junction is the other best option to mark. So, macula densa, it is present on the thick ascending limb of loop of Henle. If you don't find this answer in the options, then answer a junction between thick ascending limb of loop of Henle and distal convoluted tubule. Even if you don't find this answer, then you can go with the distal convoluted tubule if this is there. Okay, so I have given you the priority, the order which you need to know. Okay, next, what else I should teach you? These are the general things which you already know, which substances are filtered. The proximal convoluted tubule, see the proximal, after the Bowman's capsule you have the proximal convoluted tubule. The proximal convoluted tubule, yes, maximum reabsorption of the substances. Maximum reabsorption of the substances happens in the PCT, the starting part. Okay, and the proximal convoluted tubule is having the brush border. You know it, like so much brush border is there. It increases the surface area so that more and more reabsorption will happen in the proximal convoluted tubule. As it is reabsorbing most of the substances, yes, it is highly metabolically active. More number of mitochondria is there. More ATP is being used in that proximal convoluted tubule. And proximal convoluted tubule is highly susceptible to hypoxia. It requires a lot of oxygen. It is doing so much of duty. If there is no oxygen, definitely, yes, susceptible to hypoxia. Okay, done. One more point which I want you to know. See here. The most of the substances are reabsorbed in the PCT, true statement, except magnesium. Okay, so most of the substances are reabsorbed back into the blood in the PCT, except what? Except magnesium, except the magnesium. Now, after this, in the proximal convoluted tubule, what I should teach you? What I should teach you? See, the point which I want you to know is, look here. Let me show you in a simple diagram first. See, this is the glomerular capillary. Here is the glomerular capillary. Now, down to the glomerular capillary, what do we have? This is the Bowman's capsule. Down to the Bowman's capsule, what is this one? This is the proximal convoluted tubule. This is the proximal convoluted tubule of the nephron. Okay. Now, here is the loop of Henle. Now, see, this is the proximal convoluted tubular epithelial cell. These are the proximal convoluted tubular epithelial cells. Now, here, in this area, in the proximal convoluted tubule, MCQ, 100% of the glucose is reabsorbed and 100% of the amino acids are reabsorbed. Okay, 100% of the glucose, 100% of the amino acids, they are reabsorbed in the PCT itself. See here, glucose is being reabsorbed along with, this is MCQ. So, glucose is reabsorbed, but along with which ion? Glucose is reabsorbed along with the sodium ions. This is the MCQ. So, in the proximal convoluted tubule, in the PCT, glucose is reabsorbed with sodium. Also, amino acids, also the same thing. Amino acids are also reabsorbed with sodium. So, sodium amino acid co-transport, sodium glucose co-transport. Now, MCQ is, sir, this is an example of what kind of transport? So, glucose is being reabsorbed, amino acids are being reabsorbed, but along with sodium, it's a co-transport. Remember, all co-transporters are examples of secondary active transport. So, this is SGLT. Sodium, S for sodium, glucose transporter. See this transporter name, see this transporter, whatever is present over here, it is transporting glucose molecules as well as sodium molecules. So this is an example of sodium glucose co-transporter, which is an example of secondary active transport. Remember. So look here. See, glucose molecule is going along with the sodium molecule. Okay, so this is sodium glucose co-transporter, which is an example of secondary active transport. Okay, answer completed. This is the one point which I want you to know. Next, in the proximal convoluted tubule, if you look here, in the proximal convoluted tubule, I have shown you how much water is being reabsorbed. 70% of the water will be reabsorbed. In the proximal convoluted tubule, 70% water is reabsorbed. Now, look here. See, in the this is the Bowman's capsule. Okay, this is the Bowman's capsule. Okay, how much water is being reabsorbed? 70% of the water is being reabsorbed. How much sodium chloride is being reabsorbed? 70% of the sodium chloride is being reabsorbed. Now, I'm asking you, what is the concentration of urine here in this area, in the proximal convoluted tubule? whatever the urine is there. What is this urine osmolarity? What is the urine osmolarity in the proximal convoluted tubule? Yeah, I can tell you one thing in the blood, okay, and the plasma osmolarity, osmolarity is 300 milliosmoles. Okay, 300 milliosmoles. In the PCT, okay, in the proximal convoluted tubule, what happened to the plasma osmolarity? Increases or decreases? What do you think? Is it going to be increases or decreases? The plasma osmolarity will remain same, 300 only. Why? Why? Because it's the same amount of solvent and same amount of solute. The major solute is the salt, sodium chloride. So, the solutes and solvents, they are reabsorbed in the same proportion. Solutes and solvents are being reabsorbed in the same proportion. So, that's why in the proximal convoluted tubule, the urinary osmolarity is isotonic. Isotonic to plasma. In the plasma also the osmolarity is 300. And in the proximal convoluted tubule also it is 300. Okay. Done. So here see, urinary ultrafiltrate in the proximal convoluted tubule is isotonic to plasma, that is 300 milliosmoles. Okay. Now, see, try to understand like this. 70% sodium is reabsorbed, 70% water is reabsorbed. Wherever sodium goes, water follows. So, sodium is getting reabsorbed, water is also getting reabsorbed. So, this type of transport or this type of reabsorption is called as obligatory water reabsorption. Okay. So, the water reabsorption which happens in the PCT, the water reabsorption which happens in the PCT is called as the obligatory water reabsorption, which means no need of any hormones, no need of any hormonal control. Sodium reabsorbs, water reabsorbs. Okay, sodium is being reabsorbed, water is also getting reabsorbed. Simple. This type of water reabsorption is called as the obligatory water reabsorption. Done. After this, what I should know? Already I have explained to you. It's an example of sodium glucose co-transporter. The sodium glucose co-transporter is an example of secondary active transport. This is also discussed. Now, in your pharmacology, this question like will be integrated with the pharmacology. See, the sodium glucose SGLT is there, right? Sodium glucose transporter. It's actually sodium glucose transporter type 2 in the nephrons, in the kidneys, in the proximal convoluted tubule. Which type of SGLTs are there? Type 2. Sodium glucose co-transporter type 2. Actually, this sodium glucose co-transporter type 2, they can be inhibited by certain drugs. They can be blocked by certain drugs. What are these drugs? So, the SGLT2 inhibitors, they are canagliflozin, dapagliflozin and empagliflozin. So, canagliflozin, dapagliflozin and empagliflozin. Okay, these drugs, canagliflozin, dapagliflozin and empagliflozin. These drugs, okay, these drugs, they will block what? They will block the SGLT2s, okay? Is it clear? Everything is clear? Okay. So, canagliflozin, dapagliflozin and empagliflozin, these drugs, they are the SGLT2 blockers. And if you use these drugs, canagliflozin, dapagliflozin, empagliflozin, the glucose will not be reabsorbed. Glucose reabsorption does not happen. Okay, glucose reabsorption does not happen. All the glucose will go out in the urine, which will cause urinary tract infections, UTIs. Okay. Then, after this, what else you should know? See, the two important MCQs which you should never ever miss for your exam is, are in you and me. Okay, you and me guys, we are absolutely healthy, right? The plasma glucose will be somewhere around 100. Okay, round figure I am taking 100. 90 or 100 milligrams per deciliter. 90 to 100 grams per deciliter. And in healthy person's urine, do you find glucose molecules? Do you think a healthy person is going to leak the glucose? No, definitely not. 100% of the glucose will be reabsorbed in the PCT itself. Okay. So, what I am trying to put into your mind is, now understand, if you increase the plasma glucose concentration to 200, this value is important. If the plasma glucose concentration, if it becomes 200, then for the first time, what happens? Glucose will appear in the urine. See, glucose will start to appear in the urine. So, at which plasma glucose concentration, glucose will start to appear in the urine? 200 milligrams per deciliter. At 200 milligrams per deciliter, if you increase the plasma glucose levels to 200 milligrams per deciliter, some amount of glucose will start to come out in the urine. So this value is called as renal threshold for glucose. Okay, so direct value. Renal threshold for glucose is 200 milligrams per deciliter. Done. Done. Next MCQ. The next MCQ is called as a Tmax for glucose, transport maximum for glucose. What is this transport maximum for glucose? Now, to make you understand this, see, and right now I'm not talking about the plasma concentration. I'm not talking about the plasma concentration. Forget about the plasma concentration. Now I am talking about the filtered load. The filtered load. How much glucose is getting into the nephrons? Now, if it is 375, okay, if the value becomes 375, if the filtered load of the glucose, okay, I don't want to go into the calculations like how to find out the filtered load. I'm not going into that area. If the filtered load, if it becomes more than 375 value, then no further glucose reabsorption happens in the PCT. The PCT cannot reabsorb any more glucose. So, if the filtered load of the glucose, look here, if the filtered load of glucose, if it becomes more than 375 milligrams per deciliter, then there is, see, if the filtered load of glucose, if it is becoming more than 375 milligrams per, not deciliter, sorry, minute, yeah. If you put this much amount of glucose into the nephrons, further glucose reabsorption, see, further glucose reabsorption will not occur. So this value is called as the transport maximum of the glucose. So, okay guys, simple. Two values, Tmax for the glucose, transport maximum value for the glucose is 375, and renal threshold for the glucose or urinary threshold for the glucose is 200 milligrams per deciliter plasma. Okay, so these are the two important MCQ. Renal threshold or the urinary threshold. Renal threshold or the urinary threshold value is 200. Tmax value for the glucose is 375. Done. Now, after this, anything you should know regarding any other things which you should know regarding the kidney part is, look here, this is the descending limb of loop of Henle, right? Right now I am showing you descending limb of loop of Henle, and what is this one? This is ascending limb of loop of Henle. Descending limb, ascending limb. Okay, see, in the descending limb, you can clearly see water is being reabsorbed. Water reabsorption happens. So remember, descending limb of loop of Henle, right? Descending limb of loop of Henle is permeable only to water. Okay, anyway, I have written over here. See, descending limb of loop of Henle is only permeable to water. In the descending limb of loop of Henle, no ions are reabsorbed. No ions are reabsorbed. Only water is reabsorbed. That's it. Okay. So, descending limb of loop of Henle is also called as a concentrating segment of the urine. See, water is being reabsorbed. From the urine, all the water is being reabsorbed. So, what happened to the urine? Now, urine is getting concentrated. So, that's why descending limb of loop of Henle. Descending limb of loop of Henle is called as the concentrating segment. In the descending limb of loop of Henle, only water is being reabsorbed, no solutes are reabsorbed. That's it. Done, completed. Now, after this, what else you should know? Very important MCQ. This is ascending limb of loop of Henle, right? Yes. In the ascending limb of loop of Henle, look here, there is a transporter present. What is the name of this transporter? Sodium, potassium, 2-chloride. Sodium, potassium, 2-chloride is important. It is absorbing sodium, potassium, chloride, and 2-chloride ions especially. Okay, 2-chloride ions. So this transporter sodium, potassium, 2-chloride importer, it is present in ascending limb of loop of Henle. MCQ. And it is blocked with the help of a diuretic. A drug will block this. Can you tell me what is this drug? Can you at least think yourself? A drug is going to block the sodium, potassium, 2-chloride importer. What is that drug called as? That is called as loop diuretics. Okay, so loop diuretics are going to block sodium, potassium, 2-chloride importer, and the example of loop diuretic is furosemide. So furosemide is a loop diuretics which block the sodium, potassium, 2-chloride importer. Now tell me, sodium, potassium, 2-chloride importer. Sodium, potassium, 2-chloride importer, it is present on ascending limb of loop of Henle. It can be blocked. It can be blocked with the help of a drug called as a loop diuretics, like furosemide. Done. Now, Anything else which you should know regarding the loop diuretics? Here itself, let me write loop diuretics. Okay, loop diuretics. Come on, guys. I'm going a little fast, I know, but anyway, this is how it should be. Can you tell me what is the side effect of the loop diuretics? If you use loop diuretic, if I am the person who is using the loop diuretic, okay, can you tell me what happened to the calcium? What happened to the calcium, sir? The loop diuretics loop out the calcium from the body. Loop diuretics increases the calcium excretion. Loop diuretics increases the calcium excretion, no doubt. So if I am taking the loop diuretic, more and more calcium goes out of the body. Remember that one point. It's a side effect. Okay. Next thing. What else I should teach you? See, this is ascending limb of loop of Henle. Okay, everyone knows. This ascending limb of loop of Henle, it is having which charge? The ascending limb of loop of Henle, look here, it is having which charge? Positive charge. So, ascending limb of loop of Henle, it is having lumen positivity or negativity? Lumen positivity. So, the ascending limb of loop of Henle is having the luminal positivity. And they will ask you, so this luminal positivity in the ascending limb of loop of Henle, it is because of which ions? Why it is positive? It is because, see, the potassium is going to leak. This potassium from the cells, it will leak. Potassium will leak into the ascending limb of loop of Henle. Potassium is a positive ion. So because of the potassium, ascending limb of loop of Henle is having luminal positivity. The luminal positivity, again I am repeating, the luminal positivity in the ascending limb of loop of Henle, it is because of the leakage of which ions? Potassium ions. Okay, well and good. Next MCQ that will come is, sir, what is the importance of this positivity? Ascending, the luminal positivity in ascending limb of loop of Henle, it helps in, see, here everywhere positivity is there, right? See, because of this positivity, the calcium and magnesium, they cannot escape, they cannot go into the urine. So this luminal positivity, it helps in reabsorption of calcium and magnesium. So these are the divalent cations, calcium, magnesium, they are having positive charge, the positive charge. So calcium and magnesium, they cannot enter into the ascending limb of loop of Henle because more positivity is there, luminant positivity is there. Okay. So now, some important MCQs. Ascending limb of loop of Henle, which transporter is present? See here. In ascending limb of loop of Henle, please look here and tell me which transporter is present? Sodium potassium 2 chloride importer. This sodium potassium 2 chloride importer, it is blocked with the help of which drugs? Loop diuretics. When you use loop diuretics, what is the side effect? Calcium excretion. Calcium excretion. In the ascending limb of loop of Henle, which charge is there? Positive charge is there. This positive charge is because of which ion? Potassium ion. Because of the leakage of the potassium ion. This positive charge is helping in what? The positive charge, it is helping in the reabsorption of calcium and magnesium. Okay, done. Next important MCQ. Alright, look here and tell me, sir, what is this transporter in the ascending limb of loop of Henle? Sodium potassium 2 chloride importer, right? The sodium potassium 2 chloride importer, see if it is mutated by birth itself. By birth itself, it is mutated. Gaia. Okay, this is gone. By birth itself, it's gone. Then it will cause which syndrome? Then, see, let me write here. Yeah, see the sodium potassium 2 chloride importer, it is mutated by birth. Then it's going to cause a syndrome called as Barter syndrome. So Barter syndrome is due to mutation of sodium potassium 2 chloride importer. And also I have explained to you loop diuretics, furosemide. See, furosemide, it blocks which receptor? Which transporters? The loop diuretics like furosemide, yes, they also block sodium potassium 2 chloride importer. So that's the reason why I will tell you a word now. Okay, I will tell you a statement. Sir, Barter syndrome, it resembles what? Loop diuretic overusage. Okay, so Barter syndrome, it resembles, Barter syndrome looks like loop diuretic overusage. Why? Because in Barter syndrome, sodium potassium 2 chloride importer is defective. If you use loop diuretics will block sodium potassium 2 chloride importer. So the clinical manifestation or the clinical features are going to be the same. Okay, so these are the points which I wanted to know. Next, what I should teach you. So in this slide, okay, forget about this. In this slide, let me write here. See, for example, I am showing you one renal pyramid. See, this renal pyramid is divided into cortex, outer cortex, and inner medulla. You know it. So the outer part is called as the cortex. Inner part is called as the medulla. Okay, you know this, right? Now, I hope you have studied this from your regular classes. When you are going deep into the medulla, what happened to the osmolarity? In the cortex, the osmolarity is 300 milliosmoles. In the cortex, the osmolarity is 300 milliosmoles. But when you are going deep into the medulla, the osmolarity, what happens? Increases. Okay, so there is medullary, right? Medullary hyperosmolarity. How much? The medullary hyperosmolarity of 1200 milliosmoles, maximum 1200 milliosmoles. In the deep part of the medulla, the medullary hyperosmolarity is 1200 milliosmoles. Okay, who created this? This is the question. Who created this medullary hyperosmolarity? Okay, there is the importance I'm not discussing here. Why do we need this medullary hyperosmolarity? This is not the time. Who created this medullary hyperosmolarity? This medullary hyperosmolarity, it is created by, right? Medullary hyperosmolarity created by a system called as counter current multiplier system. So counter current multiplier system, MCQ. So counter current multiplier system, which includes ascending limb of loop of Henle, descending limb of loop of Henle, okay, and hairpin turn. Like it's like a turn, right? Hairpin turn. Okay, descending limb, hairpin turn, ascending limb, and hairpin turn. So ascending limb of loop of Henle, descending limb of loop of Henle, hairpin turn, they are all a part of, okay, they are all part of something called as counter current multiplier system. This counter current multiplier system is responsible for the generation or creation of medullary hyperosmolarity. Done. So once it is created, it need to be maintained. Okay, continuously. See, there is a gradient. Corticopapillary gradient means 300. Outside it is how much? 300. Little in 600. Little more in 800. 1000. 1200. There is this gradient, right? And someone should maintain this. Creation is okay, but someone have to maintain it. So who maintains? This is the MCQ. So medullary hyperosmolarity created by completed. Created by MCQ I have given. So medullary hyperosmolarity is maintained by counter current exchanger system. Okay, counter current exchanger. So who is involved in this counter current exchanger system? It is vasa recta. Okay, so vasa recta. Okay, done. So the point which I want here also say the same thing. Medullary hyperosmolarity, it is maintained by counter current exchanger. It's a typing mistake here. It is exchanger. Okay, so counter current exchanger system with the help of vasa recta. Done. So this is also completed. Guys, do you have any questions? Do you have any questions? Now in the next 10 minutes, let's complete the renal and let's directly jump into the next system. Okay, let's take a break of 5 minutes and let's start a new system. Okay, now see, let's talk about the distal convoluted tubule now. Sir, in the distal convoluted tubule, when I am talking about the distal convoluted tubule, the one MCQ which I want you to know is, sir, there is a transporter called as sodium chloride co-transporter. Sodium, potassium, 2 chlorides importer. Sodium, potassium, 2 chlorides importer is present on ascending limb of loop of Henle, no doubt. But sodium chloride co-transporter is present on distal convoluted tubule, MCQ. Okay, sodium chloride, this is the question. Sodium chloride co-transporter is present on the distal convoluted tubule. And do you know it will be blocked with the help of a drug? It is blocked with the help of a drug called as thiazide diuretics. Thiazide Diuretics. So thiazide diuretics. So thiazide diuretics blocks which transporter? Sodium chloride co-transporter. Now, important point about the thiazide diuretics is if you use thiazide diuretics, what is the relationship with the calcium? Thiazide diuretics increases the calcium reabsorption, not excretion. Loop diuretics increase the calcium excretion, but thiazide diuretics increase the calcium reabsorption. Completed. Okay, these are the points which I want you to know regarding the transporter. Sodium chloride co-transporter is present on the distal convoluted tubule. It will be blocked with the help of a drug called as thiazide diuretic. Thiazide diuretic, these drugs, they will increase the calcium reabsorption. Next point is, sir, what if this transporter is mutated? What if this transporter is mutated by birth itself? By birth itself, it is mutated. Then it is going to cause a syndrome called as Gitelman syndrome. Gitelman syndrome. So Gitelman syndrome, tell me, Gitelman syndrome, it is because of the mutation of sodium chloride symporter. Who blocks the sodium chloride co-transporter? Who blocks this transporter with the help of a drug? Who is the drug? Thiazide diuretics. So that's why we say Gitelman syndrome, it resembles what? It resembles thiazide diuretic. Thiazide diuretic over usage. Thiazide diuretic over usage. Why? Why? Because in Gitelman syndrome, same transporter is affected. And thiazide diuretics are also blocking the same transporter. In both the conditions, same transporter is being affected. So that's why we say Gitelman syndrome resembles thiazide diuretic overusage. And Barter syndrome, see, Barter syndrome, it resembles loop diuretic overusage. Barter syndrome, it is affecting ascending limb of loop of Henle. Gitelman syndrome is affecting distal convoluted tubule. Okay, so don't forget these points. Now, after this, what I should teach you? Regarding the aldosterone, in yesterday's class itself, in endocrine itself, I have discussed about the aldosterone. You know better about the aldosterone. Now, aldosterone, everything is, you know about the aldosterone. Now, here, I want to discuss about Liddle syndrome. Okay, just a 2 minutes topic. See, okay, let me draw here itself. After distal convoluted tubule, what do we have? After the distal convoluted tubule, you have the collecting tubules or collecting ducts. Okay, now we are having the collecting ducts. Yeah. See, what are these cells? These are the collecting ducts. We have cells called as the principal cells. These cells are called as the principal cells. In between the principal cells, what do we have? We have the intercalated cells. These are the IC cells, intercalated cells. Okay, here are the intercalated cells. Now remember guys, this is the aldosterone. Okay, here is the aldosterone. Aldosterone, see, it acts on the principal cells. When aldosterone, see, only when aldosterone acts on the principal cells, then these principal cells, they will start to do what? They will start to reabsorb the sodium. Okay, they will start to reabsorb the sodium and potassium is going to be excreted. Potassium will be excreted. Sodium reabsorption and potassium excretion. When this aldosterone, the same aldosterone, when it acts on the intercalated cells, aldosterone acting on the intercalated cells. Now, do you know what these intercalated cells will do? Intercalated cells, they will excrete the protons. Intercalated cells are excreting the protons. So, aldosterone, tell me what are the three functions of aldosterone? Aldosterone helps in sodium reabsorption, potassium excretion, and proton excretions. Now, for example, see, aldosterone is not there. Okay. First of all, now I am going to talk about a condition where aldosterone is not there. But do you know where is the problem? Sir, this channel, the first channel which I am showing you, okay, this channel is doing overaction. Even without aldosterone, it is continuously working. Do you know what is the name of this channel? This channel is called as ENaC, epithelial sodium channel. So this epithelial sodium channels, they are under the control of aldosterone. Okay, they are under the control of aldosterone. Whenever aldosterone is not there, then automatically ENaC activity should go down. Epithelial sodium channel activity should go down. But now, do you know what is the problem? Sir, aldosterone is not there. First of all, there is no aldosterone, but there is overactivity of epithelial sodium channels. Okay, there is overactivity of the epithelial sodium channels. Now tell me what happens. whenever these epithelial sodium channels, whenever they are acting too much, okay, whenever they are acting so much, what happens? More and more sodium is going to be reabsorbed. The sodium, more and more sodium reabsorption happens. That causes hypernatremia in the body, hypernatremia and hypertension. More sodium means more tension. Okay, so this syndrome is called as a Liddle syndrome. Okay, let me show you here. One point which I want you to know is, sir, there is a syndrome called, say, overactivity. Epithelial sodium channels, the epithelial sodium channel activity, it's under the control of aldosterone. But overactivity of this epithelial sodium channels, ENaC channels, will cause a syndrome called as Liddle syndrome. Now, done. So why I'm telling you this, because see, this Liddle syndrome, yeah, patient is going to have hypertension as well as hypernatremia. Hypertension and hypernatremia is there. Now, whenever the more and more sodium is being reabsorbed, in an exchange for sodium, more potassium will go out. Okay, so normally if you look here, see, this is the collecting duct. This is the principal cell. In the principal cell, what is happening? Sodium reabsorption happens. When this positive charge, when the sodium is being reabsorbed, that is exchanged for the potassium. Okay, that is exchanged for the potassium. So when more sodium reabsorption happens, more potassium excretion will also happen. No, so that's why due to loss of this potassium, due to loss of this excessive potassium, that will cause hypokalemia, sir. Okay, so these are some important points about the Liddle syndrome. So Liddle syndrome means simple: epithelial sodium channels are overacting. So they are reabsorbing more sodium. So there is hypernatremia in the body as well as hypertension. And there is also hypokalemia. In the body, the potassium levels are going down. Hypokalemia is there. And the patient will also have alkalosis. The patient are going to have the metabolic alkalosis. If just by heart, that's more than enough. Okay, with this, Liddle syndrome is also completed. Now, let's take a small break of 5 minutes. After the break, let's continue a small important topic in the last renal physiology. After that, we'll start a new system. Okay, take a break of 5 minutes. Okay. So we have discussed about the aldosterone. We have discussed about the aldosterone, how aldosterone is acting on the principal cells. So here you have clearly seen that how aldosterone is acting on the principal cells. When aldosterone is acting on the principal cells, you know about the things. What will happen? Sodium reabsorption happens, potassium excretion as well as the proton excretion in the intercalated cells. This is what happens with the aldosterone. You know, in yesterday's last rapid revision class also we have discussed about that. Now, after aldosterone, now let's discuss about the antidiuretic hormone. Aldosterone and antidiuretic hormone, they are absolutely different. Okay, they are not at all related. Now, this antidiuretic hormone, which is produced, which is released from the posterior pituitary, okay, which is released from the posterior pituitary, it is acting on which receptors? Antidiuretic hormone is acting on the V2 receptors. Don't forget, when antidiuretic hormone is acting on the V2 receptors, it uses which secondary messenger? It uses CAMP. Okay, don't forget about that. Next, when the antidiuretic hormone is acting on these principal cells, these are the principal cells. Okay, now not aldosterone, again I am repeating, now it is antidiuretic hormone. When antidiuretic hormone is acting on these principal cells, it's not about the sodium reabsorption or potassium excretion. Now water will be reabsorbed. So under the hormonal influence, okay, under the hormonal influence, water is being reabsorbed with the help of aquaporin 2 channels. This channel name is called as the aquaporin 2 channel. So with the help of aquaporin 2 channels, water is being reabsorbed in the principal cells under the influence of the antidiuretic hormone. So this type of water reabsorption is called as facultative water reabsorption. So facultative water reabsorption is seen in collecting ducts. Okay. Next, what else you need to know regarding the antidiuretic hormone? So this antidiuretic hormone, for example, it will be produced in excessive quantities in certain conditions, like oat cell carcinoma of the lung, oat cell cancer or the small cell cancer of the lung. See, this is a type of a lung cancer where it will produce excessive amount of the antidiuretic hormone. Okay, more and more antidiuretic hormone is getting produced from this cancer. You can clearly see here there is a cancer which is present over here, and it is producing excessive amount of antidiuretic hormone. And there are certain tumors like Kulchitsky cell tumor, okay, Kulchitsky cell tumor or the carcinoid syndrome. See, in all this condition, one thing is very much clear. More and more antidiuretic hormone is there. So now, because of the excessive amount of the antidiuretic hormone, see, there is increase, increase antidiuretic hormone. Okay, see, there is a syndrome in which the antidiuretic hormone is increased, and that is called as SIADH syndrome, where antidiuretic hormone is increased. The actual name is syndrome of inappropriate antidiuretic hormone synthesis, but for easy understanding, SIADH, syndrome of increased ADH. Now, why there is more ADH? Who is producing the excessive ADH? By lung cancer called as a oat cell cancer of the lung or small cell cancer of the lung, or carcinoid syndrome or Kulchitsky cell tumor. In all these conditions, antidiuretic hormone levels are going to be more. So what happens? It causes SIADH. What happens in SIADH? See, this antidiuretic hormone is excessively stimulating the V2 receptor. When this V2 receptor is excessively stimulated, see what is happening to the water reabsorption? More and more water is being reabsorbed. Okay, more and more water is being reabsorbed. So when more and more water reabsorption happens, see reabsorption, what happened to the urine? Less urine. More water is being reabsorbed, so less urine formation or the concentrated urine formation. Now urine is going to be more and more concentrated, not watery urine, concentrated urine. So this is called as SIADH. So in SIADH, the patient is going to have less urine volume, oligouria will be there. Is the urine is going to be in a concentrated form, or his urine concentration increases, the urine osmolarity increases. But what about the plasma osmolarity? Decreases. More and more water is being reabsorbed, so blood is like more liquid water, right? So the point which I want you to know is, so in the condition of SIADH, if you look at the urine osmolarity, urine is more concentrated, urine osmolarity increases. If you look at the plasma osmolarity, plasma, how the plasma is? You are putting more water back into your body, so plasma osmolarity decreases, the plasma concentration decreases. Okay, and as more and more water is being reabsorbed into the body, what happened to the salts in our body? What happened to the salts in our body? They are diluted. So there is dilutional hyponatremia. Now my blood is getting diluted away. The salts in my blood are getting diluted away. So there is a dilutional hyponatremia. So the important point which I want you to know in, for your exam is, sir, in SIADH, urine osmolarity increases, plasma osmolarity decreases, and there is dilutional hyponatremia. Okay, dilutional hyponatremia. Done. Enough. And what is the treatment, sir? What you need to do? Now, as a management, medical management, you can block these receptors. The V2 receptors, you can block them. The V2 receptor blockers like Vaptans are used. So the drug of choice for SAIDH is the Vaptans, V2 blockers, Tolvaptan, Conivaptan. SAIDH is also completed. Okay, in medicine you will study much more about it, like investigation of choice is water loading test. I don't want to go in detail about them. In medicine you can study. If you want to know one point, investigation of choice in SAIDH is water loading test. Even if you load the water, you ask the person to admit in the hospital, you are giving the water, you are asking him to drink as much water as possible. But even after drinking so much amount of water, still he will produce concentrated urine. So even after water loading test, still he will produce concentrated urine because he is having excessive antidiuretic hormone in his her body. Okay, so it is causing water reabsorption, dilutional hyponatremia, plasma osmolarity decreases, but urine osmolarity increases. Okay, done, sir. So the last thing which I want you to know, the last a disease which I want you to know is diabetes insipidus. What is diabetes insipidus? No ADH. ADH, simple, in a simple way I am telling you. Okay, so antidiuretic hormone is not there. Why antidiuretic hormone is not there? Maybe the posterior pituitary, it produces antidiuretic hormone, right? The posterior pituitary produces antidiuretic hormone, it is gone. Damage to posterior pituitary, no antidiuretic hormone. If no antidiuretic hormone, do you think this V2 receptor is stimulated? No, V2 receptor is not stimulated. If V2 receptor is not stimulated, do you think aquaporin 2 channels will function now? No, the aquaporin 2 channels are not there. First of all, they are not sensitized. Okay. Now, whenever the aquaporin 2 channels are not there, do you think water reabsorption will happen? Water reabsorption does not happen. All this water is lost in the urine. So now the patient is producing more and more urine, sir. Now patient is producing more and more urine. Understood? So in SIADH, there is no urine. In diabetes insipidus, there is more urine. Now, please tell me, see, more and more water is going out into the urine, sir. So what happened to the urine osmolarity in this condition? Urine osmolarity decreases. Okay, urine osmolarity decreases. It means urine concentration decreases. Why? Because urine is totally diluted away. Urine osmolarity decreases. But what happened to the plasma osmolarity? What happened to the plasma concentration? You are losing the fluids out of the body. So plasma is getting concentrated. So plasma osmolarity increases. Okay. Now, what about the sodium concentration in the body? The patient is losing the water. The patient is losing the fluid out of the body. So what happened to the plasma? Plasma is getting concentrated. So the salts in our blood, are also getting concentrated. So there is increased sodium concentration. Okay. Actually, sodium is not getting increased. Relatively, the fluids are going out, no? So relatively, the plasma is getting concentrated. Okay. There is hypernatremia. Blood osmolarity increases, urine osmolarity decreases. Okay, so these are the points which I want you to know. And here the types of diabetes insipidus. Already I have explained you one type. The one type where, see, which is called as the central diabetes insipidus. What is central? Central means something related to the brain. So in central diabetes insipidus, the hypothalamus or the pituitary gland, the posterior pituitary, they are gone. Okay, they are damaged. So no antidiuretic hormone. Simple. When no antidiuretic hormone, no V2 receptor stimulation, no aquaporin 2, no water reabsorption. All water into the urine, more urine, diluted urine. The patient is having almost like a diarrhea, but not from the GIT, but from the urinary tract. Okay, so kind of similar to more and more water is going out of the body. That's happening in the diabetes insipidus. Next problem is here. Let me tell you here itself. This was the question asked. If I am the person, imagine. My hypothalamus is damaged or my posterior pituitary is damaged. So, no antidiuretic hormone in my body. So, more and more diuresis, more and more urine loss. So, now tell me, what is the treatment? The treatment is replace antidiuretic hormone. It's the desmopressin, inhalational. So, inhalational desmopressin, puffs will come. So, desmopressin is the drug of choice for the treatment of central diabetes insipidus. Okay, central diabetes insipidus. The next type is, antidiuretic hormone is there, no problem with the hypothalamus or the pituitary gland, antidiuretic hormone is there. But there is some problem at the level of the kidneys. The V2 receptors are gone. The V2 receptors are mutated. Okay, now gone. V2 receptors are gone. So there is V2 receptor resistance. So yes, ADH is there, but it is not functional now. It is no longer useful because V2 receptor is gone. So the second type of diabetes insipidus is called as a nephrogenic diabetes insipidus, where the problem lies in the nephrons. Okay, where the problem lies at the level of the nephrons. Now they will ask you, taking which drug? There is this one antipsychotic drug called as the lithium, which is a mood stabilizer. Okay, it is used in the bipolar disorder, schizophrenia. So this lithium, if you take this lithium, the mood stabilizer, it can result in nephrogenic diabetes insipidus. It will cause damage to the V2 receptors, so the patient will have diabetes insipidus, nephrogenic diabetes insipidus. And even drugs like amphotericin B can cause a nephrogenic diabetes insipidus that will lead to V2 receptor resistance. Now, what is the treatment, sir? MCQ. The treatment is the treatment is a MCQ thing. So, central diabetes insipidus, the treatment is done with the desmopressin. Okay, central diabetes insipidus, the treatment is done with the desmopressin. But for nephrogenic diabetes insipidus, the treatment is done with the help of drugs like thiazide diuretics. Okay, so thiazide diuretics are used in the treatment of nephrogenic diabetes insipidus. And don't forget, thiazide diuretics acts on which part of the nephron? Thiazide diuretics are used, okay, thiazide diuretics, they are used to block the sodium chloride importer. They are used to block the sodium chloride importer on the distal convoluted tubule. Okay, next. So this is also completed. Next, what I want you to know. Sir, in the renal physiology, the next place where you can expect an MCQ is from the acid-base balance. Okay, acid-base balance. Every time this question will come. Now, let me directly show you the question, first of all. The kidneys, your beautiful kidneys, they play a role in maintenance of the acid-base balance. They play a very important role in the maintenance of the acid-base balance. Okay. My point is, see guys, now my point is, whenever you suffer with acidosis, and right now you are suffering with acidosis. Acidosis means what? The pH in your body, normal body pH is how much? 7.35 to 7.45 is your normal pH. Okay, this is your normal pH. If your pH is becoming less than 7.35, then it is called as acidosis. Now your pH is becoming more than 7.45, then it is called as alkalosis. Simple. First keep this point in your mind. Normal pH range is 7.35 to 7.45. If your pH is becoming less than 7.35, then it is called as acidosis. If your pH is becoming more than 7.45, then it is called as alkalosis. Acidosis as well as the alkalosis. Okay. Now, right now imagine yourself in acidosis. Right now you are having acidosis. Your kidneys have to help you, in maintenance of the acid-base balance. Acidosis is not good. That can actually kill you. So whenever you suffer with acidosis, now this intercalated cells, these IC cells, intercalated cells, do you know what they will do? So during acidosis, the intercalated cell type is called as the alpha intercalated cell. Now this alpha intercalated cell, see here what it is doing. It is excreting the acids out of the body. This is the urine side. Okay, so into the urine, more and more acids are excreting. So alpha intercalated cells are called as the acid excreting cells. During acidosis, we don't want the acids in our body. We don't want the protons. Get rid of the protons. Okay, and during alkalosis, okay, see, now the intercalated cell type is going to switch to beta configuration. Now this is the beta intercalated cells. These are the beta intercalated cells. So beta intercalated cells during alkalosis, what they will do now? They are excreting. See, into the urine, they are excreting the bases. So beta intercalated cells, they are base excreting cells. So the point which I want to put into your mind is, sir, alpha intercalated cell type is seen during acidosis. Alpha intercalated cells are acid excreting cells. During alkalosis, okay, during alkalosis, the type of intercalated cell that one you can see is the beta intercalated cell. The beta intercalated cells are base excreting cells, are bicarbonate excreting cells. Okay, during alkalosis, we don't want any bases. Already we are having alkalosis. So get rid of the bases. Okay, this is the one important point I want you to know. Intercalated cells excrete acids as well as bases. Okay, based on the situation, whether it is alkalosis or acidosis. Now, after this, what I want you to know is, next thing is anion gap. Okay, anion gap. Then what is this? What is the concept of anion gap? Simple. Remember, in your body, positive charges are there. Yes, sir. Negative charges are there? Yes, sir. Actually, the number of positive charges and the number of negative charges are equal in number. Okay. See, the major positive charge is represented in the form of sodium. Okay. The positive charges are represented in the form of sodium. And negative charges, the major negative charges are two. One is bicarbonate, HCO3 minus, and a chloride. Okay. The major things, major things. See, sodium concentration in your body is 140 minus, so positive, 140 is positive value. Okay, sodium is positive charge. So 140 minus HCO3 how much? HCO3 is 25 and chloride 105 milliequivalents per liter. 105 means 105 milliequivalents per liter, 25 milliequivalents per liter, 140 milliequivalents per liter, something like that. So 140 minus 25 plus 105. How much? 25 plus 105. It is 130 and 140. So 140 minus 130 is 10 milliequivalents per liter. This is a one single hard value. Now, but the usual range will be 8 to 16 milliequivalents per liter. So there is a gap. This gap is coming, right? What I have taught you? I have taught you in the beginning. Okay, I have taught you in the beginning that the number of positive charges and the number of negative charges are equal. But when you do the calculation, sodium minus the positive charges minus the negative charges, there is this gap coming. This gap is called as anion gap. Now they will ask you, sir, positive charges and negative charges, their value is same, no? But why here it is showing that the positive charges are more in number? Like 10 units more, no? Why it is showing more in number? It is because this anion gap, see, normal anion gap according to most of the Indian books, it is 8 to 16 milliequivalents liter. But according to some other international books, it is 8 to 12 milliequivalents per liter. But anything is the same thing. Okay, 8 to 16, 8 to 12 milliequivalents per liter is a normal anion gap. It should be considered as a normal anion gap. Okay, now they will ask you why this anion gap is because of what? Simply remember, these points. The anion gap is because of unmeasured anions. Certain anions you cannot measure in your body, like HCO3 minus, like chloride. You cannot measure certain negative charges in your body. So anion gap is because of unmeasurable anions like plasma proteins. So plasma proteins are negative charges, but you can count them? No, you cannot count them. So because of the unmeasured anions, there is this anion gap. And lactate, keto acids, which are produced in the body, the keto acid, keto acids production during ketoacidosis and lactic acid production during anaerobic glycolysis. See, because of these are all negative things. These are all anions. Anion means negative charges. Because of this unmeasured anions, you are having a normal anion gap of 8 to 16 milliequivalents per liter, or 8 to 12 milliequivalents per liter. 8 to 16 according to Indian books, 8 to 12 according to the fun books. Now, the reason why I am discussing about this anion gap is because every time this one question is kept on, they will ask you. Okay, this is an internet. I have taken this from an international book. That's why. See, here it was given 8 to 12 milliequivalents per liter, but Indian books 8 to 16 milliequivalents per liter. That's okay. See, this normal anion gap, it's divided into two. Metabolic acidosis. Look here. Metabolic acidosis, the acidosis in our body, it was actually divided into two types. Okay, acidosis, not about the alkalosis. Metabolic acidosis is divided into two types. See, normal anion gap acidosis, high anion gap acidosis. High anion gap, increase means high. Okay, high anion gap metabolic acidosis. High anion gap metabolic acidosis. And what is this one? This is normal anion gap metabolic acidosis. So metabolic acidosis is how many types? Two types. Normal anion gap, high anion gap. Agma, nagma. So only here, I am not going in detail. Why? Remember these examples. These examples is ultimate. So what are the examples of normal anion gap acidosis? Okay. So, especially here I want you to know renal tubular acidosis. In your medicine you would have studied. Sir, RTA, renal tubular acidosis, is an example of normal anion gap acidosis, sir. If the patient is suffering with diarrhea or vomitings, okay, diarrhea or vomitings, he will have normal anion gap acidosis. At least these two I want you to know. Okay, but in which conditions the anion gap increases? The patient is suffering with acidosis, okay. Not only the patient is suffering with acidosis, but the anion gap is also increased. Which conditions? At least I want you to know if the patient is suffering with lactic acidosis or diabetic ketoacidosis. okay, renal failure, methanol poisoning, okay, these things, glycols, this ethylene glycol, polypropylene glycol. See, the patient consumes, by mistakenly, accidentally, something like that. So, lactic acidosis, diabetic ketoacidosis, renal failure, these glycols, all of them, they will cause high anion gap metabolic acidosis, NAGMA. But what are the examples of normal anion gap metabolic acidosis, NAGMA? It is simple, sir. Two things, vomitings, diarrhea. Okay, sorry, vomitings, diarrhea, as well as RTA, renal tubular acidosis. If you can remember other things, yes, excellent. If you can remember, you can remember. Okay, and in some of the exams, okay, in some of the Indian exams, they will give you this, this chart. Okay, this is called as a Davenport's diagram. See this Davenport's diagram. First, concentrate on the x-axis. Okay, concentrate on the x-axis. See, this is the median, 7.35 to 7.45. This is the normal range. The 7.4 here I am giving. This is the normal pH. After 7.4, you know it is alkalosis. So that's why see here also alkalosis, here also alkalosis. Everywhere it is alkalosis only. After 7.45, it is alkalosis. Before that 7.45, or I should say before 7.35, the values are all acidosis. If you move towards this side, it's all acidosis, acidosis, acidosis. First, make sure. If you, they will simply make a mark like this. What is happening in this area? They will ask you. So that's why. First, what you should know, what you should see is after 7.45, there is alkalosis. After 7.45, there is alkalosis. Before 7.35, there is acidosis. Remember, there is this mnemonic like Rima Mere. Okay, see here, Rima, girl name, right? Like she is mine, she is Mera, something like, right? So Rima, you just keep Rima here also. Mera or Mere. Okay, so what I'm trying to put into your mind is, see, if you simply take a graph like this, let's take this as the median point. Okay, 7.4. Okay, 7.4. In your exam, they will give you an x something like this, or an x something like this. Okay, they will ask you what is happening here, or what is happening here, what is happening here, or what is happening here. They will ask you. Now you know after 7.4, what you should write? Alkalosis here. Here also alkalosis, ALK. But here it is acidosis. Acidosis. What is the mnemonic I have given you? Ma me something like this. So now, if they ask you what is happening in this X area, now you know it is a metabolic alkalosis. If they ask you what is happening in this area, it is respiratory, right? So respiratory alkalosis. Now here it is respiratory acidosis, and here it is metabolic acidosis. Okay, I'm just giving you a simple way to answer the MCQs. Okay, so this one. So this is the Davenport's diagram, which is needed, very much important for your exam. What is the normal anion gap? 8 to 16 milliequivalents per liter. Okay, and anion gap is because of unmeasured anions like plasma proteins, keto acids, lactic acids. How many types of metabolic acidosis is there? Two types: normal anion gap metabolic acidosis, high anion gap metabolic acidosis. Normal anion gap metabolic acidosis examples are renal tubular acidosis, vomiting, diarrhea. High anion gap metabolic acidosis are glycols, intake of the glycols, lactic acidosis, diabetic ketoacidosis. Okay, at least those things I want you to know, and the renal failure, many things are there. Okay, renal failure, lactates, so many things. So, is that okay, guys? Is it okay? So with this is done. Remember, Barter syndrome and Gitelman syndrome. Even in medicine also they will be integrated, and pediatrics also they will be integrated. Okay, Barter and Gitelman syndromes. Both are causing severe dehydration in the baby. Both Barter and Gitelman, they will cause severe dehydration, severe, hypotension. But Liddle syndrome, it is causing hypertension. We have discussed about the Liddle syndrome, right? Here I have shown you this one, Liddle syndrome. Liddle syndrome, overaction, overactivity. I have shown you. Liddle syndrome means overactivity. Okay, so here anyway, see, epithelial sodium channel activity is under the control of aldosterone, but overactivity of the epithelial sodium channels will cause Liddle syndrome. More sodium reabsorption, that will cause hypertension. So Liddle syndrome is a disorder of hypertension. For Barter and Gitelman, see, Barter and Gitelman, they are the syndromes of hypotension. Okay, so with this, it is completed, and I forgot to mention how to treat this Liddle syndrome. Liddle syndrome is treated with the help of a drug called as amiloride. Amiloride. Okay, what is this amiloride? Simply, alright, look here. Normally, what is this channel? This is the epithelial sodium channel, right? ENaC. The epithelial sodium channel, it's under the control of which hormone? Aldosterone. Okay, aldosterone. So now if this epithelial sodium channel, ENaC, if it is working too much, it will cause which syndrome? It is going to cause Liddle syndrome. So now you can block this. In Liddle syndrome, you can block these channels with the help of a drug called as amiloride. So amiloride is a drug which will block the epithelial sodium channels. So sodium reabsorption decreases. Okay, simple, like that. So with this, all the important topics which I want you to know completed. Now, so just as a revision, just 5 minutes revision. Okay, just check yourself. Medullary hyperosmolarity is created by whom? Who created the medullary hyperosmolarity? Can you tell me? Who created the medullary hyperosmolarity, sir? The medullary hyperosmolarity is created by counter current multiplier system. Who maintains the medullary hyperosmolarity? Counter current exchanger system with the help of vasa recta. Okay, vasa recta. Loop diuretics acts on which part of the nephron? Ascending limb of loop of Henle. Loop diuretics blocks which transporter? Sodium potassium 2-chloride symporter. Loop diuretics relationship with the calcium. Loop diuretics increases the calcium excretion. Okay, loop diuretics increases the calcium excretion. But what about the thiazide diuretics? Thiazide diuretics decreases the calcium excretion, rather increases the calcium absorption. Thiazide diuretics acts on which part of the nephron? Distal convoluted tubule. Okay, distal convoluted tubule blocks the sodium chloride symporter. Can you guys tell me what is the drug of choice for central diabetes insipidus? Central diabetes insipidus, the drug of choice is desmopressin. For nephrogenic diabetes insipidus, the drug of choice is the thiazide diuretics. Thiazide diuretics. Which antipsychotic drug? Which antipsychotic drug will cause nephrogenic diabetes insipidus? Lithium. Lithium, a mood stabilizer, which will lead to nephrogenic diabetes insipidus. Next. Guys, can you tell me where exactly the macula densa is located? The macula densa, sir, it is located in the thick part of the ascending limb of loop of Henle. If you don't find that answer, thick ascending limb of loop of Henle, then you can answer the best part is a junction between thick ascending limb of loop of Henle as well as the distal convoluted tubule. Okay, so these are the points which I want you to know. Done. See, someone is asking water reabsorption in the PCT, how much, sir? Water reabsorption in the PCT is 70%. 70% sodium chloride reabsorption, 70% water reabsorption. Okay. Now, in the next half an hour, this is a very small topic. The gastrointestinal system is a very, very small topic. In the next half an hour, let's do the gastrointestinal system physiology. Now, please tell me how many layers are there in the GIT? There are 4 layers, sir. Even small children know there are 4 layers. 4 layers are there in the GIT. What are they? Mucosa, submucosa, muscularis, and serosa. There are 4 layers in the GIT. Which layer is the strongest layer? Submucosa is strongest layer. Okay, the submucosa is the strongest layer in the GIT. Okay. Next, serosa. It is absent in. Serosa is absent in which layer? Serosa is absent in esophagus. Okay, serosa is absent in the esophagus. Done, sir. Now, in the muscular layer, there is a nerve plexus present. Okay, in muscular layer, there is a nerve plexus present. Okay, if you want me to show, see these are the muscles, right? These are the muscles. Now, in this muscular layer, are you able to appreciate all these nerves? Nerves are there, right? So, what is the name of this nerve plexus called as? This nerve plexus, here you can see, it's called as the myenteric plexus or the Auerbach plexus. And even in the submucosa, this whitish area is the submucosa. Even in the submucosa, you can see this nerve network. This nerve network is called as, let me write here, in the submucosa, there is a nerve network called as Mesangial plexus. Okay, in the muscular layer, there is myenteric plexus. Okay, myenteric plexus. Myenteric plexus helps in GI motility. Okay, GIT motility, GIT contractions. Okay, GIT contractions. This Meissner's plexus, it is helps in what? GIT contractions. The Meissner's plexus also called as the submucosal plexus. It is present in the submucosa, right? So it's also called as the submucosal plexus. It helps in GI secretions. So now tell me, Meissner's plexus is present in submucosa, so that's why it is also called as the submucosal plexus. Meissner's plexus helps in GI secretions. In the muscular layer, which plexus is present? Orbic plexus or myenteric plexus is present. Okay, so this myenteric plexus is helping in what? So this myenteric plexus is helping in the GIT motility or GI contractions or peristalsis. Serosa, it is absent in the esophagus, and the strongest layer is submucosa. Okay, so Hirschsprung disease. See, now normally, let me tell you, this is a very important thing. When you are an embryo, so the neural tube is forming. Okay, when you are at an embryo state, okay, when you are a developing fetus, you are having a neural tube. Surrounding this neural tube, there are cells called as the neural crest cells. Okay, neural crest cells. These are the neural crest cells. Neural crest. Okay, neural crest cells. So these are the neural crest cells. They are migrated to the GIT. Now in the GIT, okay, in the GIT, they form the myenteric plexus. Okay, myenteric plexus as well as the Meissner's plexus. So the point which I want you to know is the neural crest cells. The neural crest cells, they will undergo migration. Neural crest cell migration. So because of this neural crest cell migration into the GIT, myenteric plexus and Meissner's plexus are formed. Okay, both myenterics and Meissner's plexus are formed. Now what if this migration does not happen? So right here, defect in neural crest cell migration will lead to a disease called as Hirschsprung disease. Okay, so if this defect is there, do you think now the myenteric plexus and Meissner's plexus are present in that part of the GIT? No. So you are going to have a ganglionic segment, means in that particular part of GIT, no Meissner's plexus, no myenteric plexus. So if you look under the microscope, you cannot see any myenteric plexus or Meissner's plexus. So that is called as a ganglionic segment. Are you getting? So neural crest cell migration doesn't happen. So Meissner's plexus and myenteric plexus are not formed. So leading to what? A ganglionic segment. Now, in this Hirschsprung disease, this GIT abnormality, okay, this GIT abnormality, it is associated with which chromosomal abnormality? It is associated with a condition called as Down's syndrome. Okay, so if a patient is suffering with the Down syndrome, that is a trisomy 21. Okay, the Down syndrome is trisomy 21, right? So the Down's babies, they are at a risk of developing Hirschsprung disease, where the patient is having defect in the neural crest cell migration, leading to a ganglionic segment. Okay, so these are some important points which I want you to know. Next, after this, what else you should know? See, some basic important points are in your GIT, in your throughout GIT, the most acidic secretion in your GIT is HCl in the stomach. HCl in your stomach is the most acidic secretion. And what is the most basic secretion? The most basic secretion in your body is, most of the students will think that it's a bile or it's a pancreatic juice. No, the most basic secretion is Brunner gland secretions. Okay, now you will get it out. What are these Brunner glands, sir? Brunner glands, see here, Brunner glands are the mucus producing glands in the duodenum. In the duodenum, these Brunner glands will produce the mucus, which is rich in the bicarbonates. So they are more alkaline. The more alkaline secretion or most basic secretion is the Brunner gland secretion. Most acidic secretion, the most acidic secretion is the HCl, gastric secretion. Okay, completed. And some basic important things, maximum water reabsorption. The maximum water reabsorption happens in which part of the nephron? Most of the students will think like it's in the colon. Yes, in colon water reabsorption happens, no doubt. But in the jejunum, maximum water reabsorption, maximum absorption, maximum digestion happens in the jejunum. Okay, done. So after this, some important points about the salivary glands. Okay, only like go through whatever I'm highlighting. There are so many points. I don't want you to remember all these things. Only remember those points which are needed for your exams. Okay, I'm touching only those points which are needed for your exams. What's the major salivary gland? Saliva is produced by the salivary glands. Okay, what is the major salivary gland? Submandibular. It's not the parotid. Most of the students will think parotid gland is the major salivary gland. No, submandibular salivary gland is the major salivary gland. Okay, next. Uh, in the saliva, which enzymes are present? In the saliva, the two types of enzymes are present. Okay, not three types, only two types of enzymes are present. One enzyme for the carbohydrate digestion. So carbohydrate digesting enzymes are present and lipid digesting enzymes are present. But protein digesting enzymes are not there in the saliva. MCQ. In the saliva, which digestive enzymes are not there? Proteases or the protein digesting enzymes are not there in the saliva. And if you are like, if you are not a big, if you are not a beginner, if you have gone through a previous FMGE attempts, you know how much important this question is. Sir, what is salivary amylase or thiolin? Thiolin or salivary amylase is carbohydrate digesting enzyme. Okay, so in your saliva, there is something called as a thiolin, which will help in the digestion of the carbohydrates. And in your saliva, there is something called as a lingual lipase. Okay, lingual lipase. Who produces this lingual lipase? There is a gland called as Ebner's gland. Okay, Ebner's gland. Now you will get it out, sir. What are these Ebner's glands? These are minor. These are minor salivary glands. Okay, not the major salivary glands like parotid, submandibular, sublingual. These are the major things, right? So there are small salivary glands are also, which are called as minor salivary glands or Ebner's gland. So this Ebner's gland produces the lingual lipase, helps in the digestion of lipids. Completed. Next, after this, what else you should know? Parotid gland. Parotid gland. It is producing saliva, okay, but this parotid gland is innervated by, we write P something like this. So reverse the P, it will become 9. So ninth cranial nerve, the glossopharyngeal nerve is the motor innervation. So parotid salivary gland is innervated by the glossopharyngeal nerve. Okay, done. Next, other salivary glands, other major salivary glands, that's submandibular salivary gland and sublingual salivary gland. They are surrounded, they are innervated by which cranial nerves? S for S. So submandibular and sublingual salivary glands, they are innervated by the 7th. Okay, they are innervated by the 7th cranial nerve. Simple. Parotid gland is innervated by the 9th cranial nerve. Sublingual and submandibular salivary glands are innervated by the 9th cranial nerve. Okay, and one more important point which I want you to know is salivary glands. We are talking about the salivary glands. Which virus affects the salivary glands? The paramyxovirus or the mumps virus. Mumps virus belonging to the paramyxoviridae family. So this mumps virus is going to affect your salivary glands. Not only the salivary glands will be affected because of this paramyxovirus. In boys, testis. In boys, testis, and in females, ovaries. So that's why a male can suffer with. If I am imagine there is this one person who is suffering with mumps, especially children will suffer with all this. So there is this one boy who is having inflammation in his cheek. Okay, the patient is having perotitis, inflammation in the cheek, painful cheeks, and the boy is also going to present to the clinic with the pain in the testes. That's the architis, or the female that is a ophoritis. So the patient can have testicular involvement and the ovarian involvement. That is a architis, inflammation of the testis, architis or ophoritis. Okay, architis or ophoritis, inflammation of testis. Next, what else? So in the saliva, you should know which antibody is present in saliva. There is IgA antibody present, MCQ. And some basic points. See in the saliva, S for S, maximum potassium secretion. Maximum potassium is being secreted into which body fluid? Saliva. S for S. Saliva for secretion. But if they ask you maximum potassium is present, maximum potassium concentration, C for C. Maximum potassium concentration is present in which bodily fluids? Colonic. Fluids. So in the colonic fluids, you are having the maximum potassium concentration, but maximum potassium secretion into which body fluid? Saliva. Done. Okay. After this, sir. Now, this is your beautiful stomach. Okay, look at your stomach. This is your beautiful stomach. Now, if I take a small biopsy from the stomach, and I'm showing you, this is how your stomach looks like. Okay. So what you are able to appreciate here, sir, you are having glands. You are having this beautiful glands, sir. Okay, you are having this beautiful glands. So these are called as the gastric glands. Okay, these are called as the gastric glands. The point which I want you to know is, sir, see, different color cells are present, different type cells are present. Okay, am I right or not? So in a gastric gland, there are different types of cells. Right now, I'm talking about the stomach. In your stomach, okay, there are these gastric glands present. The gastric glands are made up of different types of cells. So different cells produce different substances. Okay, as simple as that. So look here, in your gastric gland, there is a mucus neck cell present. What it will produce? So first, I should write one is missing over here. That is called as a surface mucus cell. Surface mucus cell. Okay, surface mucus cell. Surface mucus cell means this cell. You see on the topmost area, surface mucus cell. So the surface mucus cell is going to produce what? Mucus, no doubt. The surface mucus cell is also called as foveolar cell. Foveolar cell. Okay, done. Surface mucus cell, also called as a foveolar cell, helps in production of mucus in the stomach. So remember, lifetime remember, in your stomach, mucus is not produced by goblet cells. 90% of the students will think, goblet cells are producing the mucus, sir. No, goblet cells are producing the mucus in the intestines, not in the stomach. Who produces the mucus in the stomach? It's the foveolar cells or the surface mucus cells. And even the neck mucus cells, this fellow also, neck mucus cell, he will also produce the mucus. But this neck mucus cell, it acts like a stem cell. This is the MCQ. What is the stem cell in the gastric mucosa? This is the mucus neck cell. Mucus neck cell. Okay, now look here, parietal cells. Parietal cells produces what? Parietal cells produces the acid. Parietal cells are also called as oxyntic cells. Okay, so parietal cells or oxyntic cells produces the acid as well as the vitamin. Sorry, not vitamin. So it produces the intrinsic factor. So this intrinsic factor helps in absorption of vitamin B12. In which region? Terminal ileum. Okay, terminal ileum. So parietal cells, they produces the intrinsic factor, helps in the absorption of vitamin B12. The vitamin B12 is absorbed in the terminal ileum. Important point about the vitamin B12. Vitamin B12 is only having, from biochemistry, very important. It's the only vitamin which have only animal source. Means you can get only vitamin B12 from the animal sources only, from milk, curd, ghee or meat, kind of. Next, the enterochromaffin-like cells. The enterochromaffin-like cells in the gastric gland, they produce something called as histamine. So this histamine, it will go and again act on the parietal cells. This histamine will go and act on the parietal cells. See, this histamine will go and act on the parietal cells. So now parietal cells will produce the HCl. Okay. Next, Chief cells. Chief cells produces what? Two substances. Chief cells produces, anyone? Think. Chief cells, what will produce? Pepsinogen. Okay, chief cells produces pepsinogen as well as gastric lipase. Okay, pepsinogen as well as the gastric lipase are going to be produced by the chief cells. And D cells produces the somatostatin. And what is the function of the somatostatin? Somatostatin decreases the acid production. Wherever you see somatostatin, it decreases everything. Okay. And last one, G cells. G cells in the gastric gland. G cells in the gastric gland. They produces gastrin. Okay. So what this gastrin will do? Gastrin will act on the parietal cells. So parietal cells will produce the acid. Okay. So understood. So now I am highlighting this. Histamine, it acts on the parietal cells. Gastrin acts on the parietal cells, helps in the production of acid. So if this is the parietal cell, now look here, see, I am showing you, this is the parietal cell. So who is stimulating the parietal cell to produce the acid? See, first of all, this is the parietal cell. How can we say this is the parietal cell? See, it is producing the acid here. Okay, it is producing the acid. So what are the stimulations for the parietal cell? See, one, I have already taught you, gastrin from G cells. It's a stimulus. And histamine from enterochromaffin-like cells. Okay, see, histamine from enterochromaffin-like cells and gastrin from G cells, they are the stimulus for the acid release. Okay, but one more thing is there. One more stimulus is acetylcholine, parasympathetic neurotransmitter. So acetylcholine, histamine and gastrin, they are all the stimulus for the parietal cells to release the acid. Okay, you got it? So these are the points which I want you to know, sir. Okay, so now if you want to decrease acid, for example, right now I am suffering with acidity, okay, gastroesophageal reflux disease, GERD. Okay, I am suffering with gastroesophageal reflux disease, or I am having ulcers in my stomach. Okay, that is the peptic ulcer disease, PUD. Now what you need to do, you need to decrease the acid. You need to decrease the acid. How can you decrease the acid, sir? How can you decrease the acid? See, you can block this receptor, histamine receptors, one of the powerful stimulus, right? So you can block the histamine receptors. So if you block the histamine receptors, acid production decreases. So histamine receptor blockers, look here. Histamine receptor blockers are H2 blockers. H2 means receptor. This name of this receptor, see, the name of this receptor is H2 receptor. Histamine H2 receptor. You can block this H2 receptor. So drugs like ranitidine and cimetidine, they are the H2 blockers. What they will do, sir? They will decrease the acid. They will decrease the acid production. Okay, done. Next point is, sir, look here, this parietal cell, it is producing acid. Okay, this parietal cell is producing the acid. Okay, acid. But from which pump? There is this pump called as a proton pump. So via the proton pump, acid is being released. You can block this proton pump so that acid release decreases. So if for most of this acid related problems like gastric esophageal reflux disease or peptic ulcer disease or a condition called as Zollinger-Ellison syndrome, I hope you have shared this in your medicine, which is called as Zollinger-Ellison syndrome, where more acid will be produced in the stomach because of a gastrinoma. Because of a gastrinoma, more acid will be produced. So in all these conditions, the drug of choice is proton pump inhibitors. So proton pump inhibitors are the drug of choice for conditions like peptic ulcer disease, gastroesophageal reflux disease. Okay, what are the examples of proton pump inhibitors? Omeprazole, pantoprazole, and esomeprazole. Okay, omeprazole, pantoprazole, esomeprazole. These are the proton pump inhibitors. Okay, these are the proton pump inhibitors. Okay, is that clear, guys? Now, after that, this is the image-based question. Guys, can you tell me what is this image-based question? Here, I am showing you the stomach. This is the stomach. I'm just cutting open the stomach, and I'm showing you. Can you tell me? Okay, can you tell me what is the problem with this image-based question? So this disease is called as, anyone? Start with the letter M. Anyone? Guys, have you ever seen this image? This is a very important image, especially for the exams. This disease is called as a Meniere's disease. Okay, this disease is called as a Meniere's disease. Image-based question. Why I am taking about this here in physiology is because, sir, we have studied about the foveolar cells, the mucus-producing cells in the stomach, the foveolar cells. If these foveolar cells, if they undergo hyperplasia, foveolar cell hyperplasia. Okay, so foveolar cell hyperplasia, that will cause a disease called as Meniere's disease. Okay, for example, imagine I'm having so much acid production. So what happened to the foveolar cells? They will undergo hyperplasia to produce more mucus. So when the foveolar cells, when they undergo hyperplasia, because of this foveolar cell hyperplasia, now you will have brainy appearance, or we will say the word cerebriform appearance of the gastric mucosa. Now the gastric mucosa is appearing like a brain. Okay, so this is called as Now this is called as a cerebriform appearance. Okay, cerebriform appearance of the gastric mucosa, which is called as a Meniere's disease. Okay, see here. Next, sir, what else you should know? I'm just trying to integrate. This is the parietal cell, right? This is the parietal cell which produces the acid. Now you should know that this parietal cell not only produces the acid. Okay, this parietal cell, it not only produces the acid, it also produces the intrinsic factor. Okay, now there is a condition where the patient is producing antibodies. See, the patient is producing antibodies, means autoimmune disease. These parietal cells at the end of the day are getting damaged. The parietal cells are neutralized. Okay, gone, damaged. Can you tell me what is this disease called as? So this disease is called as pernicious anemia. What is this pernicious anemia? Pernicious anemia means autoimmune disease where the antibodies are directed against the parietal cells. So parietal cells gone. There. Parietal cells are gone. When the parietal cells are gone, do you think acid production will be there? No, sir. There is decreased acid production, decreased HCl. When the parietal cells are gone, do you think intrinsic factor will be there? Intrinsic factor is also not there. Whenever intrinsic factor is not there, do you think vitamin B12 will be absorbed? Vitamin B12 absorption decreases. When vitamin B12 is not there, what will happen? That will cause megaloblastic anemia. Okay, the patient is going to now suffer with the megaloblastic anemia. So this is the MCQ. Okay, pernicious anemia characterized by severe lack of intrinsic factor. the patient is going to have the megaloblastic anemia, sir. Okay, and in one of the exams, this question has been asked. This pernicious anemia, we don't know the reason why. The pernicious anemia is especially seen in blood group A persons. Okay, blood group A persons. Now, one more thing. Okay, even if it takes some time, but it is worth knowing. Or imagine I am the person who is suffering with, okay, pernicious anemia. Okay, right now I am suffering with pernicious anemia. What happens? I am producing antibodies. These antibodies are coming and destroying my parietal cells. Parietal cells gone. No acid. Whenever there is no acid in my body, what happened to my gastrin levels? Gastrin levels are raising. Are no acid. Like the G cells are producing more and more gastrin, so that at least gastrin will come and stimulate the parietal cells. But parietal cells are gone. So what happened to the gastrin levels? Gastrin level increases. Okay, body want to produce the acid somehow. So body is releasing more and more gastrin, but there are no parietal cells. So in a patient who is suffering with pernicious anemia, if you look at the gastrin, the serum gastrin levels are elevated. Okay, the serum gastrin levels are very much high. Okay, now after this, what else you should know for your exams? Sir, in the stomach, which enzymes are getting produced? Sir, in the stomach, gastric lipases are there. Okay, gastric lipases are there. Okay, so in the stomach, yeah, in the stomach, gastric lipases are there, which will help in the digestion of the lipids. Okay, which will help in the digestion of the lipids. And pepsinogen is there. Who is producing pepsinogen? We know, we have discussed that the chief cells produces the pepsinogen. Pepsinogen later will be converted into pepsin, helps in the digestion of proteins. Okay, pepsinogen is there. So pepsinogen helps in the digestion of proteins, done. But remember, in saliva there is no enzyme for protein digestion. In the same way, in the stomach there is no enzyme for carbohydrate digestion. True. So there are no amylases. Okay. So in the stomach, no enzyme for carbohydrate digestion. MCQ gone. Like no, done. Next, you can ask me, sir, pepsinogen. Okay, pepsinogen is produced by the chief cells in the gastric glands. Chief cells produce the pepsinogen. Pepsinogen, it's an inactive form. Pepsinogen need to be converted into pepsin. Who converts pepsinogen to pepsin? HCl. So pepsinogen is converted into pepsinogen is converted into pepsin by HCl. Yeah. Next important area which you need to know. Now, we can eat these things like carbohydrate rich food. As Indians, we can eat the carbohydrate rich food, especially South Indians. What do we eat? Idli. See, you just try yourself. Try eating carbohydrate food like idli, and try eating protein rich food like meat, and try eating fat rich food like pizza, like which is with the full of cheese. Okay. Now, which substances do you think will stay in your stomach for a long time? Idli is a very soft thing. So carbohydrate rich things or carbohydrate rich foods will have fast gastric emptying. The food will move from stomach into the duodenum very quickly. Within just 2 hours, the food will move from the stomach into the duodenum. So that's the gastric emptying. The movement of the food from the stomach into the duodenum is called as a gastric emptying. So carbohydrate rich foods have fast gastric emptying. Okay, followed by proteins, followed by fats. Okay, if you eat proteins, they are going to stay in your stomach for a long time. If you take fats, they are going to stay in your stomach for almost half the day. Okay, so the gastric emptying time is very less. For if they ask you, gastric emptying time is, I should say in this way, gastric emptying is fastest for carbohydrates. Okay, so gastric emptying time is very less for carbohydrates. Gastric emptying time is more for lipids. Okay, so with this, the topic is also completed. Next, what else you should know regarding the gastric secretions? See, the acid which is getting produced in my stomach, it's not happening just like that during one particular period. Most of the students will think whenever you eat, then only acid will be produced. No, it's not something like that. Even if you think about the food, right now I'm thinking about some delicious food, acid production have started. So whenever something happening in your brain, that is the cephalic phase. Whenever you think about the food, whenever you smell the food, whenever you look at the food, yes, 30% of the acid is going to be produced in the stomach. Okay, 30% of the acid is going to be produced in your stomach just with the thought of food or smell of food or looking at the food. Okay, so vagus nerve will be activated, the parasympathetic nerve and the vagus nerve will be activated. Okay, that produces the 30% of the acid. And when you actually eat the food, you have gone to the restaurant and now you are eating, or you went to your home and you are eating. So whenever you eat the food, then in the stomach gastrin will be produced, and this gastrin mainly will help in the production of acid. Gastrin is, of course, gastrin, histamine, acetylcholine, all, but mainly gastrin. So gastrin will help in the production of more acid, 60% of the acid. When you eat the food, 60% of acid is produced. When you think about the food, 30% of the acid is produced. So even after, see, even after the food is going into the intestines, some amount of acid will be produced, 10%. So that is called as intestinal phase of gastric acid secretion. So how much? 10%. Okay. So you should know 30, 60, 10. Cephalic phase, gastric phase, intestinal phase. 30%, 60%, 10%. Completed. Now after this, next important MCQs. Absorption of substances and their important sites. Iron. Where it is absorbed, sir? Iron is absorbed in duodenum. Where B9 is absorbed? Vitamin B9 is absorbed in jejunum. Okay, where vitamin B12 is absorbed? Vitamin B12 is absorbed in terminal ileum. Okay, terminal ileum. So iron in the duodenum, vitamin B9 is absorbed in the jejunum, vitamin B12 it is absorbed in the terminal ileum. Now from microbiology, this was the question which was asked in the 2019 June FMGE exam. They have simply asked Diphyllobothrium latum, which of the following is a fish tapeworm? This is the question asked. Diphyllobothrium latum, which is a fish tapeworm, do you know where it will live? It lives in the terminal ileum. Now whenever it is living in the terminal ileum, it will cause inflammation over there. It decreases the absorption. It decreases absorption of which substance? In the terminal ileum, vitamin B12 is absorbed. So the patient is now going to have vitamin B12 malabsorption, leading to botryocephalus anemia. Whenever vitamin B12 is not there, that will cause megaloblastic anemia, right? So this megaloblastic anemia, because of B12 deficiency, seen due to a parasitic infection like fish tapeworm infection, is called as botryocephalus anemia. Diphyllobothrium latum, right? So that's a botryocephalus anemia. Okay. So now tell me, botryocephalus anemia is due to deficiency of vitamin B12. Botryocephalus anemia. Where is the problem? In the terminal ileum. This fish tapeworm is living over there. Okay. Next, there is a parasite called as the Ankylostoma duodenale. In the name itself, it is a duodenale. Ankylostoma duodenale. So if it is living in the duodenum, it causes what? It causes iron deficiency. Whenever there is iron deficiency, that will cause iron deficiency anemia. It's a type of microcytic anemia. Microcytic anemia, MCQ, which you need to know. Okay, done, sir. After this, I want you to know a few important points about the iron absorption. Okay, where iron absorption happens, you know it, duodenum. Okay, iron absorption happens in the duodenum. Iron absorption happens in which form? Which form? Only Fe2 plus form. Okay, I'm not going in detail, only important points. Only iron is absorbed in Fe2 plus form. But imagine me being a vegetarian, I'm a pure vegetarian. Now, if I'm taking the plant, products, if I'm taking a plant products, I will get which form of iron? Fe3 plus form of iron. So I am getting Fe3 plus form of iron right now. Okay, I am getting Fe3 plus form of iron. But do you think Fe3 plus form of iron is absorbable? No. Fe3 plus form of iron is not absorbable. But I don't have any problem because this Fe3 plus form of iron is converted into Fe2 plus form with the help of acid. The acid which is present in my stomach, the acid which is present in my stomach will convert the Fe3 plus form of iron into Fe2 plus form of iron. Ferric iron will be converted into ferrous iron. So now this ferrous iron will be absorbed into the duodenal enterocytes, into the duodenum with the help of a transporter called as DMT1. Okay, DMT1, which is called as a divalent metal ion transporter 1. Okay, divalent metal ion transporter 1. No need to remember the full name. Simple, DMT1. Transporter helps in iron absorption. Fe2 plus form. Fe3 to Fe2 plus by HCl. Okay, if you don't find HCl in the option, then you can also answer this as vitamin C. Vitamin C, that's the ascorbic again acid. Okay, ascorbic acid. So vitamin C, also called as the ascorbic acid, will help in conversion of Fe3 plus form of iron into Fe2 plus form of iron. So iron absorption is increased by acids, vitamin C. But if someone asks you who decreases the iron absorption, the iron absorption is going to be decreased by milk. Remember, iron absorption is decreased by milk. Okay. So at the end of the day, iron is absorbed. But where iron is, see now, at the end of the day, iron is going to come into your blood. Absorbed. Iron is absorbed. In the blood, iron is now bounded with a plasma protein. There is a plasma protein which is binding with the iron. What is the name of this plasma protein? MCQ, transferrin. So transferrin is a plasma protein which is binding with iron. Transferrin is a plasma protein. Again, I'm telling you, in the blood, iron is not allowed in free form. No, you should not allow the iron in the free form. In the blood, iron is bound with a plasma protein called as a transferrin. Okay, so this transferrin, what it will do? It will transfer the iron to liver. So in the liver, iron is stored in which form? Fe3 plus form. So the storage form of iron is called as ferritin. Ferritin. Okay, so ferritin is Fe3 plus. We store our liver. We store iron in which form? Fe3 plus form. Okay, Fe3 plus form, not Fe2 plus form. But Fe2 plus form of iron is absorbable. Fe2 plus form of iron is absorbable. Where iron is getting stored? Iron is getting stored in the liver, as well as iron is stored in the bone marrow also. Bone marrow macrophages. In the bone marrow macrophages, iron is stored. Now, in your exams, especially your FMGE exams, when you have sufficient amount of iron in your body, I am having enough amount of iron in my body. Is there any further need to absorb any extra iron? No, iron is not a good thing, to be frank. Okay, so once if iron enters into your body, it will never come out. Iron doesn't have any specific mechanism, or we humans does not have any specific mechanism to excrete the iron. Once iron enters into the body, it will stay lifelong, no doubt. So when you already have enough amount of iron, you should not absorb any other iron. So that's why whenever you have sufficient iron stores, the liver will produce a molecule called as MCQ, hepcidin. Hepcidin, what it will do? It will inhibit the iron absorption. Okay, right? Let me write here. Hepcidin inhibits iron absorption. Okay, hepcidin inhibits iron absorption. So regarding iron, please answer my questions. Iron is absorbed in which form? Fe2 plus form. Who will convert Fe3 plus form of iron into Fe2 plus form of iron? Acid or ascorbic acid. Who will decreases the iron absorption? Milk. Which transporter is helping in the iron absorption? Divalent metal ion transporter 1, which is present on the duodenum. In the blood, iron is bound with which plasma protein? Transferrin. Iron is stored in which organs? Liver and bone marrow. In which form? Fe3 plus form, which is called as ferritin. Ferritin. When you have sufficient stores of iron in your body, liver will produce which molecule? Hepcidin. Hepcidin inhibits the iron absorption. Done. Now after this, some important points about the pancreas. Pan, see the name itself, it's there, pancreas. Pan means complete. It will produce enzymes which will completely help in digestion of proteins, carbohydrates as well as fats. See, what are the pancreatic enzymes? Simple. Pancreatic amylase helps in digestion of carbohydrates. Now, what is the enzyme for protein digestion? Trypsinogen chemotrypsinogen and procarboxypeptidase. So trypsinogen, chemotrypsinogen, procarboxypeptidase, they help in the digestion of proteins. And what is the enzyme which is produced by the pancreas? To digest the lipids. It's the pancreatic lipase and colipase. So pancreatic lipase and colipase, these are the enzymes which will help in the digestion of lipids. This will help in the digestion of the lipids. So pancreas, pan means complete digestion. Pancreatic enzymes digest carbohydrates, proteins and fats. Carbohydrates, proteins and fats, all of them will be digested away. Next, my point which I want you to know is, sir, this trypsinogen and chemotrypsinogen, the ogens, trypsinogen, chemotrypsinogen, what are they? These are the zymogens, because these are the zymogens which are inactive in nature. See, so this trypsinogen need to be converted into trypsin. Trypsin is the active form. Chemotrypsin is the active form. So who will convert trypsinogen into trypsin? Its answer is enterokinase. So enterokinase, which is present in the intestinal juice, just remember, pepsinogen is converted into pepsin with the help of acid, HCl. But trypsinogen is converted into trypsin with the help of enterokinase. Now, one more question which I want you to know is, see, can you answer this? Pancreatic enzymes are produced like trypsinogen, chemotrypsinogen. are produced in inactive form. Why inactive form? Why? Why? Because to prevent autodigestion of pancreas. Okay, so to prevent the autodigestion of the pancreas, these enzymes are produced in inactive form. Okay, these enzymes are produced in inactive form. Now, after this, what else you should know in the GIT? Regarding duodenum, two hormones are there, which I want you to know, only two hormones. See, in the duodenum, there is a cell called as S cell and I cell. Duodenum have S cells and I cells. First, let's talk about the S cell. When you eat the food, the acid is getting produced in the stomach. Now, this acid, it will enter into the duodenum. See, now acidic chyme, partially digested food, the food which is mixed with the acid. Now, it is entering, okay, now this is entering into the duodenum. It is stimulating which cell? S cell. Now, do you know what this S cell will do? S cell helps in the production of something called as secretin. This secretin is the first hormone discovered in humans. Okay, secretin is the first hormone discovered in the human cell. Now, the secretin, what it will do? Sir, secretin acts on pancreas. Okay, secretin is acting on pancreas. Now, do you know what pancreas will do? Sir, pancreas, it will produce this bicarbonate rich to neutralize the acid. Now, pancreas is releasing more and more bicarbonate rich pancreatic juices. Okay, simple. This is the problem. Acid is the problem. So, in order to neutralize the acid, bicarbonate rich pancreatic juices are released. So, now, see, this is what happens. You take the food is mixed with the acid. This acidic chyme enters into the duodenum, stimulate the S cells produce secretin. Secretin will come to the pancreas. Pancreas, now it is producing more bicarbonates to neutralize the acid in the duodenum, not in the stomach, in the duodenum. Completed, sir. Now, other thing. This other cell is called as the I cell. Sir, what is this I cell? When you eat fat-rich food, okay, when you eat fat-rich food, mainly I'm talking about. So when you take fat-rich food, these fatty acids, they will stimulate the I cells. Okay, fat-rich food, these things, they will stimulate the I cells in the duodenum. Now these I cells, they are going to produce something called as cholecystokinin, pancreozymin, full form, cholecystokinin. So this cholecystokinin, see, this cholecystokinin, it acts on the pancreas. Yes, cholecystokinin acts on the pancreas. And cholecystokinin also acts on the gallbladder. Now think logically and tell me, what's the problem? You have taken the fat-rich food. Let's consider it as a problem. You are eating fats. These fats need to be digested, no, somehow. Who will digest the fats? Bile. Bile actually does not have any enzymes for fat digestion, but it does something called as emulsification. We need the bile. Whenever you take the fat-rich food, you need to have a process called as emulsification of fats. So bile should be there. So that's why whenever you eat fat-rich food, the fat-rich food will stimulate the I cells. I cells produces the cholecystokinin. Okay, I cells produces the cholecystokinin. Now this cholecystokinin, pancreozymin, it acts on the it acts on the gallbladder as well as it acts on the pancreas. In both the places it will act. So now see, whenever the gallbladder is getting stimulated by CCK, now what will happen? Gallbladder will start to contract, sir. So what it will do? Contraction of the gallbladder releases the bile. So that's why this cholecystokinin is called as cholegog. Okay, cholegog means the one which causes the contraction of the gallbladder. The one which causes the contraction of the gallbladder is called as a cholegog, and the cholegog is cholecystokinin. Cholecystokinin is an example of cholegog. Okay, so bile is released. Done, sir. Completed. Not only that, see this cholecystokinin pancreozymin. Know what it is doing? This cholecystokinin pancreozymin, it is acting on the pancreas. Now, fat. Now you are eating fat. No, this fat need to be digested. So that's why now pancreas, it is producing what? See, now the pancreas is producing pancreatic juices rich in pancreatic lipase, co-lipase. So pancreatic juices are released with rich in enzymes. Okay, to digest the fats. Okay. Then in a simple way, please answer my questions. Sir, in the duodenum, how many types of cells are there? Two types of cells are there. S cells, I cells. What is the stimulus for the S cell? Acidic chyme. S cell is going to produce secretin, or you can say what is the stimulus for the release of secretin? Acidic chyme. What secretin will do? Secretin acts on the pancreas, so the pancreas produces more bicarbonate-rich pancreatic juices. Next thing, when you eat fat-rich food, the fat-rich food is going to stimulate what? I cells. The I cells are going to produce something called as a cholecystokinin. The cholecystokinin will cause the contraction of the gallbladder, one thing. releases the bile, and the cholecystokinin also acts on the pancreas, so that now pancreas will produce enzyme-rich pancreatic juices. Okay, so with this, the two important hormones are also completed. Okay, now after this, directly what I want you to know is the one GA hormone. Okay, one GA hormone, sorry, not one, two GA hormones which I want you to know regarding motilin as well as ghrelin. Who produces this motilin in the intestines? This motilin is produced by M0 cells or MO cells. Okay, motilin is produced by MO cells. In the name itself is there, motilin. Motilin helps in the motility, GIT contractions. Okay, motilin helps in GIT contractions. Okay, my question here is, the motilin increases the GIT motility, no doubt. Motilin is acting on which receptor? Motilin acting on motilin receptors. Motilin, it is acting on its receptors, own receptors called as the motilin receptors. But see, imagine this is the GIT. Okay, this is the GIT. Intestine. Here are the motilin receptors. Imagine these are the motilin receptors. Now these motilin receptors are stimulated by what? Motilin. Motilin stimulate the motilin receptors. But not only that, see, there is something called as erythromycin. Not erythro. Okay, this is called as erythromycin. But this erythromycin, it can also come and stimulate the motilin receptors. So what happens whenever the motilin receptors are stimulated? What happens? That increases the GIT contractions or GI motility. So the point which I want you to know is the motilin receptors is also stimulated by, this motilin receptors are stimulated by erythromycin, a drug called as, not myelin, erythromycin. So what is the side effect of erythromycin? I'm having some fever, I'm having some infection, I came to you. You gave me erythromycin. Yes, erythromycin is an antibiotic, it's an antibacterial, okay. But erythromycin also go and stimulate the motilin receptors. When motilin receptors are stimulated, more GIT contractions, diarrhea. So side effect is diarrhea. Okay, so that's the one important MCQ which I want you to know. And if I suffer with, for example, imagine I'm a diabetic and my GIT motilities are very less. That is called as a diabetic gastric paralysis. Okay, so diabetic gastric paralysis, my GIT motilities are very, very less. So what you need to do as a doctor, you need to increase the GIT motility. How can you increase the GIT motility? By stimulating the motilin receptors. By stimulating the motilin receptors, you can increase the GIT motility. So the point which I want you to know is, sir, how can you stimulate the motilin receptors? Again, see, this erythromycin, it is used. Erythromycin is used in the treatment of gastric paralysis. Erythromycin stimulate the motilin receptors, GIT motility increases. Simple. Next thing which I want you to know is ghrelin. Okay, sir, ghrelin in yesterday's class in endocrinology also I have discussed. Ghrelin is produced by epsilon cells. Okay, epsilon cells in pancreas. The epsilon cells in pancreas produces something called as a ghrelin. When during fasting, ghrelin is going to be produced. Sir, what this ghrelin will do? Sir, ghrelin increases the hunger. Sorry, it's a typing mistake. Ghrelin increases the hunger, the feeling of hunger. Okay, I'm like having hungry, right? Whenever you are fasting, you'll have the hunger. So who will give you that hunger feeling? This is because of the ghrelin. And this ghrelin not only increases the feeling of hunger, it also increases the growth hormone production. Just go and check the endocrinology. Same thing I have taught you there. Ghrelin is produced during fasting state, increases the feeling of hunger. It also increases the growth hormone level. Okay, so these are the points which I want you to know. At least these three things. These three things are important. Okay, now after this, what else I should teach you? See, in the GI motility, the points which I want you to know is the last. We are at the end almost. The next 10 minutes, we can complete this. So, what is a pacemaker? Your GIT is contracting like this. Okay, your GIT is contracting. What is the pacemaker cell of the GIT contraction? SA node is the pacemaker of the heart. Okay, and what is the pacemaker of the GIT contraction? The pacemaker of the GIT contraction is interstitial cell of the caudal. Okay, the pacemaker in the GI motility is interstitial cell of the caudal cell. MCQ. Okay, MCQ. So this interstitial cell of caudal, there are many interstitial cells of the caudal. Like many interstitial cells of caudals are there. Okay, SA node is only one in the heart, but there are many interstitial cells of caudal. Now, point which see this interstitial cell of caudal, they are extending from the body of the stomach. Okay, they are extending from the body of the stomach till to the colon. These interstitial cells of caudal are there, no doubt. Guys, In the entire GAT, the most important area is this one. Okay, this is the most important area. Questions will come from this area only. Okay, especially in FMGE exams and PG exams, this is the most important area. Now I am showing you. See, this is the interstitial cell of the Kajal. Okay, now in this interstitial cell of Kajal, there is some electrical fluctuation happening all the time. Okay, some electrical fluctuation from negativity to coming towards the positivity, it's again going back. Negativity to positivity, again going back. So this electrical alteration is happening all the time. 24/7 it is happening. So this is called as basal electrical rhythm, BR. Electrical alteration, just voltage of the cell is now fluctuating like this. Okay, so this is called as the basal electrical rhythm. So this basal electrical rhythm, MCQ, they are not action potentials. They are not action potentials, and they are not causing GIT contractions. They are not responsible for GIT contractions. Okay, now right now in my interstitial cell of Kajal, there is this electrical fluctuation going on. Okay, but now I'm thinking about the food. My parasympathetic nervous system is getting activated. Now I'm thinking about the food. I'm looking at the food. I'm smelling the food. Now do you know what happens? Vagus nerve is releasing the acetylcholine on this interstitial cell of Kajal. See, now this is the vagus nerve. What it is releasing? It is releasing acetylcholine. When it is releasing the acetylcholine, now look and tell me what happens. See, now it's coming like this. It is having some spikes. Now this is not just the basal electrical rhythm now it is having some extra spikes. These are called as the spike potentials. Okay, these are called as the spike potentials. So these spike potentials are the action potentials. They are the real action potentials. Okay, these are the real action potentials. Now they are responsible for these action potentials. This is spikes. They are responsible for GIT contractions. Okay, this is the MCQ. Okay, so the same thing, look here. Now initially what do you have? You are having the basal electrical rhythm, simple basal electrical rhythm. But see, when the acetylcholine is acting, okay, when the acetylcholine is acting, see now you are having spike potentials, 2 spikes, 3 spikes, more than number of spikes. You can ask me what is the difference between the spikes, sir? 1 spike, 2 spike, 3 spike. Now look at here. Here I am talking about the electrical recording, electrical fluctuation. But here I am talking about the mechanical recording, contraction. Whenever there is a basal electrical rhythm, there is no contraction in the GIT. Okay, the GIT, there is no contraction, sir. Okay, see, but whenever spike potentials are coming, 1 spike potential, little contraction. 2 spike potentials, see, the strength of contractions are increasing. Okay, after action potential, the strength, more the number of action potentials, more powerful contractions are coming. More the number of contractions are coming. Okay, so this is what I want to put into your mind. So acetylcholine is responsible for this spike potentials. But sympathetic nervous systems, you are sympathetically activated, you are in a hurry, you are about to fight. At that time, do you want any GIT contractions? No, right? So that's why, see, epinephrine, what it is doing, sympathetic neurotransmitter, it is decreasing, see, from 3 to 2, 2 to 1, 1 to again back to basal electrical rhythm. So what is happening to all GIT contractions? It's also coming back to 0. So basal electrical rhythm, no contraction. So this is what I want to put into your mind. So please tell me, sir, what are these electrical fluctuations which are happening in the interstitial cell of Kajal? So these electrical fluctuations are called as the basal electrical rhythm. Are they action potentials? No, they are not action potentials. Are they causing any GIT contractions? No GIT contractions. Then what are the GIT? Then what is responsible for GIT contraction? It's the spike potential, SP. The spike potential, they are the real action potentials. They are responsible for GIT contraction. And who is causing the spike potentials? Is the acetylcholine. The acetylcholine. See, one more MCQ. I have said you, I have so many interstitial cell of Kajal. So many interstitial cells of Kajal are there. Okay, so many interstitial cells of Kajal. So, there is an interstitial cell of Kajal in the duodenum. There is an interstitial cell of Kajal in the cecum. Now, let me show you. Very small, important thing. This is the interstitial cell of Kajal in the duodenum. There is an interstitial cell of Kajal in the cecum. Okay, now see, in the duodenum, what are these are the basal electrical rhythms, you know. So within a time, see how many basal electrical rhythms are there? More or less? More. But in the cecum, if you see, how many basal electrical rhythms are there? Less. So this is the MCQ, sir. So in the duodenum, more the basal electrical rhythm. Every minute you can have these 12 waves. Okay, so 12 fluctuations are coming, 12 slow waves. See, this basal electrical rhythm is also called as a slow waves. So 12 slow waves are coming. So highest frequency, this is the MCQ, highest frequency of the basal electrical rhythm is present in duodenum. Least frequency of the basal electrical rhythm is present in cecum. Done. These are the two MCQs completed. Highest frequency in duodenum, least frequency in the cecum. Answer. And the last thing for gastrointestinal system is simple: peristalsis versus segmentation. Most of the student knows about the peristalsis, but no one knows about the segmentation. What is the difference? The type of motility. Both are GIT motility only. Both are GIT contractions, but they differ in the way they are happening. See, peristalsis means one side it is contraction. One side of the GIT is contracting. Okay, you have taken the food. Food is there in the intestine. To prevent the regurgitation back, this proximal segment is undergoing contraction and the distal segment is undergoing relaxation to welcome the food. So, what is happening? With the time food is moving forward, the proximal segment is getting contracted and the distal segment is relaxing. So, the food propulsion is happening. Okay, so MCQs which they will ask you in exam is, sir, the proximal segment is getting contracted. Because of which neurotransmitter? Acetylcholine and substance P. MCQs. So which neurotransmitters are responsible for the contraction of the proximal segment? The neurotransmitters MCQ is acetylcholine and substance P. Then which neurotransmitter is responsible for relaxation of the distal segment? It's getting relaxed to welcome the food. Which neurotransmitters? The neurotransmitters are nitric oxide and vasoactive intestinal peptide. Okay, so they are causing relaxation. Okay, relaxation of the distal segment. They are causing contraction. Okay, these are the MCQs. Now, if you look at the segmentation part, see in this segmentation part, see the proximal segment is contracting as well as the distal segment. Both are getting contracted. So both proximal segment and the distal segment both are getting contracted. So now the food is divided into small boluses. Okay, now the food is getting divided into small pockets. And now what is happening is not just the propulsion. Now here the food is mixed with the digestive enzymes. The food is getting digested away. So both the proximal segment, distal segment, both are contracting. Helping in the food digestion is called as segmentation. And this is the major GI motility. This is major. Okay. So most of the people will think only one thing. Peristalsis is the GI motility. No, peristalsis is not the GI motility. Segmentation is the major GI motility when compared to the peristalsis. Now I am asking you one question. Tell me. Both peristalsis as well as segmentation. Okay, both peristalsis as well as segmentation. Both of them are happening when? During fed state or unfed state? Both of them are happening during both of them are happening during fed state only. Means yes, there is a food. See, here there is a food, here there is food. Okay, here both these places there is food is there in both the type of motility. One is helping for the propulsion of food, peristalsis for propulsion of the food. Segmentation is for digestion. Okay, segmentation is for the digestion of the food. Okay, you got my point. But now you haven't eaten anything. Now, for example, imagine right now you are sitting. You are not eating anything. Still, your GIT will undergo contractions. Even without food, your GIT will contract. That is called as migratory motor complex. So, migratory motor complex, okay, it is seen during fasting state. So, which GIT motility is seen during fasting state? It is the migratory motor complex. So, a powerful wave of contraction, it is starting from the stomach. Okay, see a wave of contraction, a contraction wave is going to start from the stomach and it is going till to the colon. Okay, this contraction is going even without the food, even without eating the food. Why? To clean any residues. If there is any leftover material, it need to be cleaned. It need to be cleaned, right? So this migratory motor complex, it cleans the GIT. So that's why it's called as the broomstick or sweeper. Okay, broomstick or sweeper of the GIT. Migratory motor complex seen during fasting state. It is called as a broomstick or sweeper of the GIT. Why? Because it cleans the GIT. What it is doing, sir, actually, it is cleaning and preparing our GIT for next meal. So it prepares the GIT for the next meal. And do you know who mediates this migratory motor complex? M for M. Migratory motor complex, it is maintained or it is mediated by motilin. Don't forget about the motilin. Motilin receptors are stimulated by erythromycin. Okay, remember that point. So, motilin is mediating the migratory motor complex. And if you are fasting, if you are not eating anything, one migratory motor complex is going to be seen in every 90 minutes. One migratory motor complex will start It will move from the stomach till to the colon. It will clean the GIT. Okay. So with this, all the important points, we have completed gastrointestinal system. We have completed the cardiovascular system, renal system, as well as we have done the endocrine system. I'm again telling you guys, if you go through this rapid revision of physiology, all MCQs will be covered, no doubt. So this is the part 2 of the rapid review series is done. So in the next part, in the part 3, that will be the last part. That's the last part. In that last part, let's cover the remaining systems. 2 important systems are there. That's the CNS as well as the respiratory, along with the general physio topics. So that will be done in 1-2 days. That will be done. Most probably we will inform you. That will be happening most probably day after tomorrow. So with this, the second part of the rapid review series is also completed. Hope the video is helpful. If you have any doubts, you can all the time contact us on Telegram or WhatsApp groups. The PDF will be shared in the group. Thank you guys.